Assalamu alaikum wa rahmatullahi wa barakatuh. Ladies and gentlemen, good morning and welcome to the third day of the 5th International Conference for Mass Gathering Medicine. As we gather here once more, we are filled with a sense of anticipation for the enlightening discussion and ideas that await us today. We are commencing our first session on research, development, and innovation. We are privileged to have our two distinguished moderators leading the way. Please join me in welcoming Prof. Osama Samarkandi and Professor Imad Al-Jahdali. Professor Osama Samarkandi, he is the Dean Prince of Sultan bin Abdulaziz for AMS, King Saud University. Prof. Imad Al-Jahdali, he is Dean, College of Medicine, Al-Qura University, former Deputy Minister. Welcome, Professor, and the floor is yours.
Assalamu alaikum. Good morning, everybody. I would like to introduce our first honor speaker, Dr. Ziad Mimish. Prof. Ziad Mimish is the senior consultant in infectious disease and director of the Research and Innovation Center at King Saud Medical City, Saudi Arabia. He holds the NMD from the University of Ottawa and board certified by the American Board of Internal Medicine, the American Board of the Infectious Disease, and the Royal College of Physicians. Prof. Mimish is a pioneer in the mass gathering medicine and infections control, and he established WHO Collaboration Center for Mass Gathering Medicine and Infection Control in Saudi Arabia. He is the chairman of the National Scientific Technical Advisory Group for COVID-19 and the chairman of the Technical Advisory Group on COVID-19 vaccine under the Royal Court. Please welcome everybody, Prof. Mimish. And I would like also to honor Dr. Raja Al-Raddadi, our second speaker. Dr. Raja Muhammad Al-Raddadi is a physician with an MD from Saudi board in a preventive medicine and public health, master in medical education diploma in clinical research, and preventive cardiology diploma. She is an associate professor at and consultant chairman of the Scientific Council Saudi Board Preventive Medicine, head of Community Medicine Department at King Abdulaziz University, and board member of Arab Board in Community Medicine. Dr. Al-Raddadi published 139 articles and had received several awards, including Mohammed bin Rashid First Award in Cardiovascular Disease and Faculty of Medicine highest H-index within the period of 2020 to 2023 from King Abdulaziz University. Welcome, Doctora.
Assalamu alaikum. Good morning, everyone. I would like to introduce our third speaker, is Dr. Bayan Al-Sharif. Dr. Bayan is the Director of Hajj and Umrah Research and Epidemiology Administration in King Abdullah Medical City in Mecca, Consultant of Preventive Medicine and Public Health. Dr. Bayan. And our fourth speaker is Dr. Jamie Rice. He's Associate Professor of Mass Gathering Collaboration in Griffith University. He's recognized internationally for his work focusing on strengthening the health systems for disruptive events that are either unplanned, such as disaster, public health emergencies, extreme weather, or planned, such as mass gathering, major events, deliberate acts of harm. He has over 100 peer-reviewed publications in the area of disaster and mass gathering health. And with that, we'd like to start. Please go ahead.
Yeah, thank you, Prof. Ahmad. Yeah, within the Research Development and Innovation RDI, I would like to welcome Prof. Ziad Mimish. And Dr. Ziad, please, the mic is all yours.
Thank you very much, Shukran. I have some slides that I want to present, if that's possible.
Yes, please.
I think I'll just go there. Okay, so it's a pleasure and honor to be here, and I know this is it's going to be a short presentation, 10 minutes, so I have to look at my watch. I'm not going to basically go into details because this is a group of experts who are dealing with Hajj and Umrah and mass gathering for a long time, but we all know that the key definition for mass gathering, which is basically any large event that will overcome the capacity, public health capacity of a country or a host of this event. And definitely this definition has removed any links to numbers because it will vary depending on the size of the community. Why do we worry about mass gathering medicine? Being an infectious disease person, and we have gone through many pandemics, recently the COVID, we know that infectious diseases are the most common problem encountered in mass gathering events. We have a high percentage of people coming from low-income countries, misuse of antibiotics. These countries seem to be endemic for multiple infectious diseases. And of course, in many of these events, because of the crowdness and the busyness of the organizers, there's usually poor surveillance and there are suboptimal preparedness for pandemics. And of course, Hajj is by definition is the largest mass gathering, largest annual recurring mass gathering event in the same place. It's been going on for many years. And this basically map shows the majority of the people that come to the Hajj from all over the globe. And the bigger the arrow, the bigger the population that come from that region. And to know the top 10 countries that send pilgrims to Saudi Arabia, this is the list of top countries. And of course, as you know, India, Indonesia, Pakistan, and Turkey are the top 4 countries that send pilgrims to us. What's unique about the Hajj is that people wait for a long time before they can come to the Hajj. So 60% of the population that attend the pilgrimage or the Umrah tend to be on the older side with ages above 60 years, which makes it very difficult to manage their comorbidities and ensure their safety and well-being. Of course, in the past and continuously, preparation for mass gathering is important. And I know many years ago when I was in the ministry, we used to work the whole year before preparing for the mass gathering event, which is for 2 weeks. And the whole country is basically promoted or prompted to work on this event. Now, with the Umrah expanding very fast, basically we have Hajj the whole year long. So this is a huge challenge for our colleagues in the Ministry of Health and Public Health. And of course, we always ask ourselves what might happen, how will we know when it happens, and what we will do when things do happen during the event. And these are the 3 key questions that are asked by the people overseeing any organization of mass gathering event. This is an old picture of the mosque many years back when the mosque was much smaller. Surveillance is very important. On a national level, there's a high-level committee chaired by the governor of Mecca, and then there is also a Ministry of Health committee chaired by the Minister of Health, and there's a committee that is chaired by the Deputy Minister of Public Health that oversees all the activities of the Hajj. And there's always collaboration with all the government sectors involved, including international partners like WHO, European CDC, and Public Health England. And of course, we have utilized IT technology in the past to do surveillance through the mobile teams that visit the healthcare, the camps for the different pilgrims, and also the teams that are within the facilities in the Hajj premises. And this is the old disaster center or the management center, and I think it's much more improved and expanded. And basically, we used to collect data on a regular basis, and this screen gets updated every 5 minutes, gives you an update of where the pilgrims are, how many in the hospital, how many with what diagnosis, and then based on this, a dispatch of teams go to different hospitals to address outbreaks and concerns. And also, there have been new technology used to using the electronic bracelets in 2016, which has made a huge difference. If you look at the numbers of pilgrims over the years, they increased until 2013 and then dropped for 4 years because of the expansion of the Grand Mosque. And now, of course, we have Vision 2030. If you look at the upper left side of the slide, you see the expansion involving the areas on the top left side of the mosque, which basically doubled the capacity of the Grand Mosque. The Vision 2030 is to increase the capacity of the Umrah visitors from 8 million to 30 million per year by 2030. We have the Mecca Route Initiative, which basically have the Ministry of Interior and Immigration officers of Saudi in countries like Pakistan, Malaysia, Indonesia, Turkey, and other countries to basically expedite the process. When the pilgrims come to Saudi, they directly go out from the airport, and their bags go before them to the places where they're staying. And of course, the new thing that happened is the expansion in tourism, and we expect to have 100 million visitors per year in 2030, and there's a huge investment in tourism with $810 billion being invested to expand tourism. Of course, we're always concerned about emerging pathogens and outbreaks, and of course, the pathogen X, and we've already had experience with pathogen X with COVID, where everything was paralyzed for 3 years. The question is, how would the Ministry of Health or the Public Health Authority in the country pick the first case of disease X, God forbid if it happens in KSA? And I love this diagram because it shows you that, you know, how many people travel and come to the Hajj in green, and then how many of them will have an infectious disease in yellow. And you want to pick up that one person or one cluster, which is a small red dot, who has something that is new and could cause a huge outbreak and on a global level. And this is a huge challenge for the Ministry of Health for many years and for many years to continue. Of course, why would we worry about outbreaks? Because the cost is incredible. It can paralyze the economy of the country, and it can increase cost to the global community. We should be prepared for future pandemics by having a system of universal health coverage, digital technology, pandemic preparedness plan, evidence-based practice, and transparent communication with the public. And of course, we need to upgrade our diagnostic systems, and now we have Wuqaya with the Saudi CDC or the Gulf CDC, which has state-of-the-art technology. We have to invest in new technologies, which is the wastewater analysis, which is a powerful public health tool that can detect things before they actually emerge among the human people and then human cases. And then you can see all the diseases that can be surveyed through wastewater surveillance. And I know that Wuqaya has already started this almost a year ago by collecting samples from wastewater. And of course, investing in digital technology or in artificial intelligence, which will help you to detect outbreaks early and detect cases early by improving diagnostics and also modeling for new cases. I think the Hajj and Umrah of 2023 has shown that we are back to a state of normal. Basically, Umrah is fully activated and upscaled. By the first 20 days of Ramadan this year, we've had 22 million Umrah people coming to the kingdom. The Hajj visa quotas went back to the pre-COVID area with no age restrictions. So I think there's a huge challenge for the Ministry of Health in the future to deal with mass gathering events, whether it's tourism or whether it's religious or other sport activities. But I'm confident that the resources and the support available and the resources within the Ministry of Health will be able to cope with these new challenges. Thank you very much for your attention.
Thank you, Prof. Mimish, for the presentation. Yeah. I also would like to introduce our second honor speaker to give the presentation. And meanwhile, we have the option that we can go with the question and answer, or should we post it to the end of the session? To the end of the session. Then please, Dr. Raja.
السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه أجمعين. It's my pleasure to present with you today talking about the challenges facing research on mass gathering and global health security. I'll talk about mass gathering and global health in a few slides, then talk about the published research on the same topic, and finally the challenges facing researchers and countries and other institutions. I will start with the objective mentioned lastly on the special issue in the Journal of Infection and Public Health, talking about mass gathering and health security research activities and describing it as a multidisciplinary in nature and often talking about access challenges, evaluation, emergency phenomena, and investigating efficacies of policies, practice, and regimen implementation. All of these put this research on several challenges. And I tried to go through the literature review, seeking information about the reported challenges by the researcher on both topics. However, I found 3 reviews on mass gathering published during 2022 and 2023. The first one published in 2022 is a bibliometric analysis, and the second one is comprehensive narrative analysis. Unfortunately, only one systematic review summarizing research on mass gathering, and I tried to find the challenges facing the researcher on this paper published recently. The first one is health-related research publication on religious mass gathering of Muslim. It was a bibliometric analysis for the research published on the same topic from 1980 to 2020. And they found Saudi Arabia is number 1 in the frequency or percentage of the publication on mass gathering. And also they talk about the articles, the type of document published, either articles, review, letter, or any other type of publication. 68% was articles. And here we can see the growth of publication and citation of religious mass gathering of Muslim regarding number of publication and number of citation. There is sharp increase in number of publication and citation within the years from 1990 to 2020. Also, the paper identified the top researcher. That's why I'm looking for the researcher have high publication and high citation on the same topic to identify the challenges that they can face. Fortunately, with us here, Dr. Ziad Meimesh is number 1, and he contributed to 21% of the publication worldwide. There is another 2 national researchers published on the same topic. The second publication or review on mass gathering was the healthcare research in mass religious gathering and emergency management. It was a comprehensive narrative review. They look for the gap in mass gathering, and they classify the mass gathering publication into fully examined or unanswered question or partially examined. And after that, they found insufficiency or gap in research that will be presented with another degree and, during the day. And the third one is the only one systematic review on the social norms and risk of mass gathering, published in 2023. But they have criteria for including the study in the publication. If the study on infectious disease or non-infectious or health-related illnesses, alcohol-related risk, and sexual-related risk for any mass gathering event. And they usually took all publication, quantitative, qualitative, and also mixed method. Unfortunately, the inclusion criteria was only English language and with full text publication. That's why there is limitation for the publication on this site. They identify 138 papers on 83 mass gathering in 42 countries, and I tried to identify some challenges with this paper reported from the researcher. Type of mass gathering studies was 43 in religious mass gathering, 24 for sport, and 21 for music festival and other cultural festivals, contribute for 18% of the whole publication. Here, one of the most important slides, when they assessed the quality of the included research, they found the high score quality only 50% of the publication, with medium scores quality 42, and low assessment score quality in 8% of the publication. And I think those papers with medium score quality and low score quality have several challenges when they collect the data or during the process of publication. Also, the quality assessment include all research, qualitative method, which contributed to 93%, quantitative method, which contributed for 93%, qualitative 6%, and mixed method only 1% of the published paper. Also, they studied the distribution. The place, 53% was in Mecca, and also type of risk, they classify the publication on health, behavior, environmental, and mental. The majority of the publication in health and behaviors give us a hint that this is have a very important point, that there is strength in data collection, or it's easier than other part of the publication to get data and to publish that research. Also, the religious math gathering have 85% for health, 38% for behavior, and 23% for environmental, 9% for mental health and other. Also, the majority of the research in the health and behavioral risk would reflect that there is less challenges facing research in this area. Although the last systematic review published, the protocol was based on the International Prospective Registration of Systematic Review, Prospero, and it was conducted following the procedure of the prepared recording item for systematic review and meta-analysis. It was not concerning with the topics related of mass gathering research. It's only looking for the distribution and classification of the published research and the area looked for from the researcher. I tried to classify the challenges. It's on a macro level, for example, the Global Mass Gathering Center, Ministry of Health, or at a meso level in Mecca City when they tried to prepare for Hajj, or at a micro level in hospitals during Hajj, and there is challenges facing the researchers themselves. Also, I tried to classify also according to the time. Is it before Hajj, during Hajj, or after Hajj? Before Hajj, the difficulties reported by the researcher is the data collection was inaccurate related to requirement for participating in the mass gathering, including medical test or proof of vaccination. And also some of the researchers document that there is barriers or challenges for the use of smartphone application by the pilgrims, and also education or educational level or health literacy of the pilgrims was one of the challenges before Hajj. Behaviors of the pilgrims, risk perception for the disease and infection is one of the challenges. And finally, getting ethical approval and official approval, it was one of the challenges. I think this is related for that the researchers don't know the nature of Hajj and the time-related issue, which make the data collection is difficult, and it's very difficult to conduct that if you didn't prepare yourself advance before Hajj. I tried to summarize during Hajj, the challenges during Hajj. As we all know, the nature of Hajj, the short duration, transfer from place to place, the stressful condition, changing sleep, changing diet, everything changes for the Hajj, and also make them very difficult to make any interview or any data collection with them. Also, the limited time in each place if we want to collect the data in Mina or Arafah or any other place. The third one is the diverse of population with the change in the background, language, and all other behaviors, risk perception, and also high demand on health services during mass gathering makes it difficult to take any data from the health institute. Also, availability of fund. Even if the fund is available, sometimes the researchers don't know the exact fund they need for the research during Hajj. Another one is methodological aspect of the research. I will take it on the next slide. Ethical and official approval, as we mentioned before Hajj, and data availability and quality is one of the main concerns. After Hajj, the majority of research published after Hajj, it was on the returnee from Hajj. And I think we need for the international research agenda, talking about the identification of the importance of the research, prioritization of the research, and make the agenda clear for the whole researcher to align in the same line and to get a lot of publication that we can examine this research and systematic review. Challenges associated with mass gathering, as mentioned in a lot of papers, that health system having to accommodate the surge of capacity to give the researcher time and space for collecting data, challenges to existing health intervention, introduction and transmission of non-endemic disease during and after mass gathering make it the priority for tackling this infection, and the researcher find them they have no access to the data or they couldn't get the official approval. Also, difficulty associated with communication to participants from different culture, different difficulties because of high profile of some event and such a security risk and information gap regarding pilgrims' health. Methodology-related aspect for the design, for example, it's very difficult during Hajj to make interventional study, even sometimes if you want a duration between the collected data at the beginning of the study, then make the intervention and collect the data after that, short duration of time and the nature of the pilgrims and also difficulty in distribution of them in their campaign and also the language barrier. Sampling is very important. Sometimes the researcher couldn't identify the sample frame to generalize their result of the research, and the difficulties mentioned before in data collection. Finally, applicability of the proposed methodology sometimes make it difficult to get either ethical or official approval. Regarding global health security research, it was easier for me to identify the publication because I found some publication talking about the challenges facing the researcher. The publication on global health security was international and regional local, and there is 2 systematic review identify the barriers that include heterogeneity of data source, slow adoption of technologies, limited resources, quantity and complex nature of data, organizational and structural barriers, different data and reporting policy. The second systematic review, also published in 2022, talking about some challenges facing global health security research, including weak data management, weak electronic reporting system, absence or weak mechanism of information exchange between international health regulation and animal health focal points, insufficient health professional specialists, insufficient capacity for court test confirmation, insufficient specimen referral system, issues in laboratory licensing and accreditation, weak quality management system. However, all these acknowledged and published challenges was internationally. In conclusion, research in mass gathering and global health security are essential. Addressing research challenging is vital, and identification the challenges at each level, macro, micro, meso, and at a researcher level, also before, during, and after Hajj is very important. With building a good research team or collaboration is important to overcome these challenges. With this, I can say for you, thank you very much.
Thank you, Dr. Raja. I would like to call Dr. Bayan Al-Sharif for the third presentation.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, everyone. This is Dr. Bayan Sharif, Preventive Medicine and Public Health Consultant, Director of Hajj and Research Administration in King Abdullah Medical City. As known, research is the basic step for the future. And as part of future vision for SAID 2030, we plan to reach up to 30 million every year for Umrah pilgrims. Other aspect is facilitating inflow of pilgrims and gaining easy access to the two holy mosques, delivering high-quality service to Hajj and Umrah pilgrims, and enriching religious and cultural experience to Hajj and Umrah pilgrims. To achieve all this vision, Saudi Arabia have been working in the following. We have been working in the third expansion for the two holy mosques, modernizing and increasing the capacity of Said Airport. We launched also the Mecca Metro project to complement the railroad and train project that will serve visitors to the Holy Mosque. So according to the World Health Organization, having 1,000 people at a specific location for a specific purpose for a defined period of time is considered as mass gathering. And in Saudi Arabia, we have a lot of mass gathering. We have religious event, Hajj and Umrah in Mecca and Medina. We have a lot of celebration and concert. We have the National Day. We have a lot of entertainment like Jeddah season, Riyadh season, which started just 2 days ago. We also have sports events. We have the Saudi League. We will have also the Olympic, which will be starting, inshallah, in the next month. So because of all this new development in our Saudi Arabia, we have to assess our need and come up with innovation that facilitate these events. So local need driving innovation, it refers to the phenomena where innovation and solution are developed to address specific challenge and requirement that arise when large group of people come together for event or gathering. Innovation can involve creating from scratch, adapting or significantly modifying an existing creation, or introducing a new and improved approach, device into society. So to identify local need in mass gathering, we have 5 main categories. We have the healthcare and medical service. We have the infrastructure and logistic. We have environmental impact, safety and security, and communication and information. Let's start with medical service. During mass gathering, we have a lot of risk that the people attending, the organizer will face during this mass gathering. We have communicable disease, we have a non-communicable disease, we have the risk of suffocation, risk of fires. So all of these risks have to be addressed, and we need to assess in order to develop innovation. Preventive healthcare program is one of the most successful planning for this event, and this is the work or the vision of 2030. And let's not forget, vaccination and education is one of the foundation. We have here one interesting papers in the posters that education among Malaysian pilgrims who have education, their attitude towards vaccination become more positive. So education is a very important part to the people. And here in Mecca or in Saudi Arabia, all participants during Hajj must receive Hajj vaccination, which is meningococcal vaccine and influenza vaccine. For pilgrims, they should also, it's required for them to get vaccination like meningococcal, influenza, yellow fever for those who are coming from endemic area. Innovation in this area could include mobile clinic. We also have in Riyadh season the Gulf car that is to facilitate the access to the patient and help them immediately. We also have one of the innovation is the rapid diagnostic test, which can help the physician to decide whether to isolate or not. We also have the telemedicine, one of the innovations that we can use during mass gathering. Infrastructure and logistics. Mass gathering requires significant infrastructure for transportation, accommodation, sanitation, and crowd management. Innovation in this area could include designing efficient transportation system, temporary structure, crowd control technology. We have the infrastructure development in King Abdulaziz International Airport City in Jeddah. As now in Jeddah is the main entry for pilgrims to Mecca, to Jeddah, and to Mecca and Medina. So they have been increasing their capacity. They increased the service, so the disabled pilgrims, the older pilgrim, they have easy access in the airport. Safety and security. Ensuring safety and security of attendance is crucial at mass gathering. Innovation in this area could include surveillance, communication, emergency response system, and crowd monitoring. We have also one of the most successful examples in Saudi Arabia, Tawakkalna app, which was developed during the pandemic of COVID-19. This app will show for decision maker as well as the visitors. If they want to book for Umrah, for visiting in Al-Madinah, they will show if it's crowded or not, and if it's full or not, so they can plan according to this application. Dissemination information to a large number of people in real time is crucial, especially during disaster. If there is a fire, like for example in mass gathering, calming down the attendants, evacuating them, guiding them to the evacuation, preventing them from crowded. This is one of the most important and crucial areas. Innovation in this area could include communication technology, mobile app, information disseminated system that can tailor to specific requirement of the mass gathering. And in Saudi Arabia, electronic bracelets have been implanted. This is a simple barcode, show the campaign that the Hajj come with, the location of its campaign. So if Hajj is lost or missing, the authority can immediately locate them and direct them to the right place. Environmental impact, mass gathering can strain local resource and have an environmental impact. Innovation in this area could be waste management, water conservation, and sustainable energy solution. Culture and religious requirement. In the case of religious gathering like Hajj, innovation may be driven by the need to accommodate the unique requirement ritual associated with the event. And one of the most successful stories we have is the Hajj Hackathon. It is performed under different umbrella. Here we have Tarjuman application. This was in 2018. It was organized by the Saudi Federation of Cybersecurity. They came up with a mobile application. It was defined by 5 Saudi women. It's simply, Hajj scan the barcode, it simply translate the signboard into his language without the needing to the internet or the Wi-Fi. This is their application. And just launched recently is Pharmacist in Barcode. This is launched by Makkah Health Cluster. It is a digital service to facilitate obtaining drug information and side effect using the latest modern technology. There will be a session, inshallah, afternoon about this with Dr. Hatim Al-Amri, if you are interested. So, come to the challenge of innovation in healthcare system. We have limited budget, demand is increasing, public expectation are rising, and accepting failure as part of the innovation process is a must. Anything new you start, you have a chance of failure. So accepting this is one of the most important things we have to accept. To sum up, if you have in your setting, in your local need, in your setting, you have a problem, you have an issue, you have opportunity, and if you are working in a hospital, or are working in a primary care center, you come up with new technology, with business model and social initiative. This is considered innovation. I will leave you with 10 seconds of commitment by our Saudi division just to read it. And may Allah bless us and guide us to the right path. And thank you.
Thank you, Dr. Bayan. I would like to welcome Dr. Jamie Rames for the fourth and final presentation, and then after that, we'll open this the session for questions and answers. Thank you.
Thank you very much for the opportunity to speak with you today. It's a pleasure of mine to be back in Saudi Arabia again here at this magnificent conference. I'm going to be talking today about some of the research priorities for mass gatherings. So what do we know really about some of the research that's been conducted? Well, in terms of a medical subject heading, mass gatherings has only been introduced into that browser in the last 18 months. This recognises that the field of mass gathering medicine research is somewhat new. We can pull some data from various sources to have a look at how much research is being produced under this particular heading. If we go to somewhere like Scopus or CIVA, we see that the number of scholarly outputs is increasing dramatically year on year. However, unlike the research that we just saw previously about the Hajj research, here we start to see that the citations don't necessarily match the likelihood of increasing scholarly outputs. And if we look at the discipline areas, it's no surprise that the majority of it is from medicine. However, we also note that mass gathering health or medicine-related research is somewhat multidisciplinary as well. What we know once we start to drill down and look at the types of research is that they're quite broad in nature. They're looking at the events of international significance, including Olympics, Hajj, and other major events around the world. They'll include things of national significance and also include the types of events that you'll see every day or every weekend in your local community. I think this is important for Saudi Arabia as we start to see more and more larger types of events occurring in your nation. The types of studies and design that we see, predominantly retrospective patient-driven data-related research. Some are simple descriptive in nature of single types of events or cases. And then there are large amounts of prospective research, which is predominantly cross-sectional surveys of attendees or their health attributes of those attendees at events. What we have a look at in the literature, though, is when we have a look at trying to determine, well, what are the health outcomes we are trying to research from mass gatherings, it's somewhat poorly defined. There are some literature sets, and probably the infectious diseases literature sets, which is a little bit clearer around this, but the broader mass gathering literature is not so clear. So how do we define what health outcomes we're interested in researching at mass gatherings? And secondly, the outcomes that we do research are predominantly data-driven rather than hypothesis-driven. And we probably need to start shifting to be more hypothesis-driven so we can start making some more inferential understandings about the complexities of mass gatherings in the context of our research. The topics, as we've just heard previously, are predominantly around the infectious and communicable diseases at major events, and then the second largest area is around health service provision and predominantly the in-event health service provision at mass gatherings. So, now we've got an idea about what we do research. What should we research? So I think we should start, as I mentioned, doing some research more around the inferential elements of mass gatherings to have a better understanding of the relationships and the complexities of different aspects, from event design to the people that are attending and how they influence the health outcomes of people at your event. There's two ways we can start to think about this, and that is we could research the same type of event, concert, festival, marathon, in different locations to get an understanding if there's some contextual differences in the locations that make a difference to the health outcomes. Or perhaps we could have a look at the different types of events in the same location to determine if it's the different event typologies that actually influence patient outcomes. And what do I mean by patient outcomes? For those that were in my presentation yesterday, it was predominantly for me around two things. One is, how do we ensure we have appropriate health services for people at the events so that they have the best and optimal outcomes? And how do we protect the community in which the events are being held? That is, how do we make sure we have the same normal operational capacity of our ambulance, hospitals and emergency departments and so on in the vicinity of those events? If we have a look at the terminology that's used within the literature, this is starting to improve, and we're starting to see some more common terminology. We've done some work over the past decade or so to try and, particularly in the in-event health space, to come up with some commonality in the words in which we're using to describe mass gatherings and the health outcomes of those particular events. So we can start to compare, at least if people are doing individual case studies, we can at least start to compare those when we go to do literature reviews and so on, and start to do some meta-analysis type work in the mass gathering space. Starting to broaden our understanding of mass gatherings as well, not purely just about patient presentation rates and transport to hospital rates, but what are those other things that might influence those? More than just necessarily the biomedical, psychosocial, environmental factors, but what about the event design and event safety elements of the event, the timing or scheduling of events that are occurring, the built environment and how that impacts on patient outcomes and injuries and illnesses as well. And then what do we do with all of that data and how do we use it? So I think we should still do individual events, particularly if in terms of research, particularly if there are things of interest of that event which we don't already know in the literature, if there's something new to learn. Otherwise, I think we should be doing some larger multi-site, multi-sectorial type research to develop a better understanding. I think the research that we do needs to be useful and usable. That is, we should be doing things to support decision-making around health service provision at mass gatherings. Now, we see over the course of the conference many examples about how data is driving decision-making. Large amounts of dashboards, large data sets which drive those dashboards to help people operationally in the event undertake some decision support. What we don't see in the literature, though, is some good examples about how these particular dashboards, what elements of the dashboards and the data that we're collecting are actually helping inform those decision-making aspects. So that if I was to start my own event, what things should I need to consider in the dashboards that would be useful to me? And in those dashboards, moving from the element of doing research for forecasting or predicting what might happen in the next event to forecasting, rather nowcasting and having an understanding of what's going to happen now so that we can put appropriate resources in the appropriate spaces. And it's very interesting to hear just earlier the concept around the Hajj, where we can start to see large increases of patient presentations at different venues and therefore relocate our health services to those events. So that type of nowcasting is really important, and we need to describe that more in the literature about how that's helping decision support. Data imagination and interoperability is really important, and we know that it's hard sometimes when we've got multiple sets of data, how we actually integrate those to make sense of what we would like to research, but also, again, around decision support. And then I think we need to move beyond aspects which we think of as predominantly normally medical related, and have a look at those other aspects, those things which might influence our patient workload at events, and consider the interplay between these different aspects in terms of our health and patient outcomes. We've heard already some barriers to research, and these aren't necessarily barriers specific to mass gatherings as such, but I'll try to put a mass gathering lens on them. Sometimes the research we want to do at mass gatherings is reliant on the organisers' cooperation. So whilst we as researchers might have a good idea about what we want to do and how to do it, particularly for some other events, it may not be possible because it relies on the commercial in confidence information that we're expecting to receive from an organisation to help support our research. So some challenges there. Again, consider the need to do research for the purpose of just doing research versus the need to do research to have some operational significance and again help you supporting the decisions that are making around health workforce, infrastructure and physical resources to help communities. Previously, we heard some of the barriers as well around funding and timeframes. I completely agree with those. Sometimes the funding for research related to disasters and mass gatherings is somewhat limited because the budgets go into the operationalisation of the event and how we provide the services at events, rather than thinking about how we might evaluate and research the event as well. So to encourage people to think about how we can integrate some budget into the operational aspect for the evaluation and research of major events and mass gatherings is really important. Throughout the conference, we've heard a couple of really key aspects related to research. We need to continue to build the evidence base. We know that this is a field which is somewhat new, so we need to continue to build some high quality evidence around health service delivery, health service aspects and health outcomes. Continue to use the data-driven approaches, and as we see AI and machine learning become more significant, we're going to see more larger data sets, and it's about how we make sense of those practically for mass gatherings. I've mentioned before some of the challenges around data sharing, particularly between different organisations who might be involved in the event, and the ownership of that data, and how you might overcome some of those is quite challenging, and that integrates in just the overall aspects of the research complexities. So where to from here? A couple of key things. One is, I think, to have research and evaluation of mass gatherings integrated into your event or operational plans. Should not be an afterthought, should not be something that we just think 2 years later, oh, we should have really researched or done at least some evaluation from a quality perspective of an event. But instead, this should be something that is integrated within all of our event plans and operational plans. Think about some of the health positive research that we might be able to do. So here we're talking lots about protecting the health and well-being of people at events, but what if there were some things that we could do which actually left people leaving the event in a better health state than when they first arrived at the event, whether that be around health literacy, aspects of chronic management of their health and well-being, or whatever it may be, but maybe there's something as a health multidisciplinary group we can do to have positive health outcomes and improve health outcomes from people at events. And then, of course, as I've mentioned multiple times now, consider those other influential factors, not just the health pieces, but the built environment and other aspects which might influence health outcomes at your events. And again, those health outcomes relating to the people at the event and also in the communities in which the events are being held. I'd like to thank you very much for your time.
Thank you so much.
Thank you, Jimmy. Yes, now we would like to open the discussion from the audience. If someone have any question for our honored guest, please go ahead. Yes, please.
Thank you so much for the panelist. I remember I did my first Hajj in 2022 with my wife. I like research very much. I escaped and I took a note and write about what are the priorities when it came to research. It's quite obvious we need to have a research agenda for Hajj. So the research agenda, it will help us. What are the priorities? What are the major problems? And then based on this, we'll have the research agenda for the coming 5 years. And then most of the stakeholders, they can help with answering the research agenda. It's quite obvious, each institution, they have their own objectives, their own interest. But it's obvious we can solve the issue of funding if we have a research agenda. And then based on the research agenda, you can have your operation plan, and then the budget and the monitoring and evaluation. And then you can evaluate. This area still, you have the gap. This area, we done, good. We need to prioritize. And this is how to orchestrate. And you have a lot of experience, you have a lot of know-how, a lot of, centers. The research agenda will help most of the problems. In terms of funding, the research, the payback of the research, it can be a lot. And then by this, you can help and you can serve the global health agenda. Thank you so much.
Thank you so much. I think some of the very important presentations made in this session were saved definitely for the last day. So thank you so much. It's really extremely encouraging what you have presented. My only question is, I mean, there's been a lot of research going on. Is there any thoughts about the wastewater surveillance as well, especially during Hajj, because it pre-warns about so many things? It could be bacterial like Salmonella, Vibrio, it could be viral, and that's what we practically did in COVID as well. So any possibility in the near future thinking about the wastewater surveillance and genomics on that? Thank you.
Thank you. Who wants to take this question? Prof. Ziad.
Thank you. I think for the first question from Dr. Muzaffar, the issue of research and planning, as you probably heard, there's a new entity in the country called Research Development Innovation Authority. This has been established by the government and now it's official. It will be in charge of all research that takes place in the country. And they have presented the proposed agenda to His Royal Highness the Crown Prince. And the first pillar that would be addressed in the first 3 years of research with full funding is actually infectious diseases and also reducing outbreaks during mass gatherings and such events. So I think this will be a big priority over the next 3 years to be addressed. To address the second question about wastewater testing, as I mentioned in my presentation, this has already been initiated by Waqaya, which is the Saudi Public Health Agency, almost I think during the time of the COVID, and now they're expanding into polio and other viruses and antimicrobial resistance. So it's already being executed.
Anyone's? Thank you. Is there another question from the audience? Doctor, please.
Yes, I would like to ask one more question for Dr. Sorry.
Thank you very much. Very enlightening presentation. Just kind of following up on the point of my colleagues. And I'm really glad to see Prof. Memish and Prof. Osama here with their expertise in thinking about, and Dr. Raja, of course, how can we align the priority? Let's say we identified some priorities with ongoing graduate programs in the kingdom. So we have at least 5 master's programs in the kingdom. And one of the challenges dealing with many of the students is the topics are really not novel and not contributing to the need for the country. So obviously, with your expertise, with colleagues in Center for Global Mass Gathering, there is a lot of topics that could be addressed by graduate theses within students. And I think having this alignment, if there is annual priority of those are the topics that the country needs. Aligning with the universities, so either College of Public Health, College of Medicines, and these are the annual 50 list that we need your students and go to explore, and we will support them with data at least if there's some funding. Adding to that, building a bridge with, as Prof. Memish mentioned, RDI, saying this is the priorities. We need a little bit of funding to support those graduate students. I think that would be a really big win-win for all, for the country, for the students, because we've seen a lot of students end up doing low-quality research that contribute nothing to the need of the country. So I guess my question to esteemed colleagues is how can we, if you do believe this is a viable solution, how do we move forward? Thank you.
Thank you. That's a great question. I guess
and I'll just make a quick comment, and maybe Dr. Raja can follow up. No, I agree with you 100%. I think, in the past, universities and academias used to do research. At some point, the Ministry of Health took over and did some of the research. But I think everybody has to be involved. And I'm very glad that RDIA has, put their foot down, and basically they're going to be in charge and overseeing the whole research in the country. And it will not be one single entity. It will not be the Mass Gathering Center. It will not be the Ministry of Health. It will not be King Saud University. It will not be, a certain entity. It will be multi-sectorial work coordinated hopefully by the RDIA and the Saudi NIH to do research. There's plenty of research. One entity cannot do everything. So I think unless you open the door and put the list of priorities and invite everybody to apply and then give them funding and coordinate and monitor, we will be doing this every year, discussing what are the priorities. But I think RDIA is on the right step, and I'm looking forward to seeing how things progress over the next few years.
Thank you, Dr. Ghannam, for highlighting this issue. I agree with you that we need a comprehensive research agenda classified into, as I mentioned, to all domains, all topics, all level and times. After that, we can identify the challenges for each domain. And I mentioned at the end of my presentation that collaboration and presence of collaborative centers either nationally, regionally, or internationally, they can acknowledge all of these challenges to help us to implement our research agenda. So we have a key of success if we work on this. The second point, you mentioned that prioritization inside the research agenda. I think we need a comprehensive research agenda with annual prioritization. I think this is the key for success. If we work on this, we will reach maybe about 50% of our planned improvement in the research and acknowledge the challenges of the research at the level of Mass Gathering Center, Ministry of Health, International Global Health Security, and at the level of researchers themselves. Thank you very much.
Thank you, Dr. Raja. Yes, we'll take one more question, then.
Shukran for the superb presentations. I think Hajj has really excellent study and research capabilities and facilities for infectious diseases, for mass gathering disasters. But I think we should also start looking at the comfort of the pilgrim. As Professor Memish mentioned, about 60% of the pilgrims are 60 years or older, and a lot of them will only perform, in fact 99% of them will only perform this once in their lifetime. So what we should look at is actually asking the pilgrims what were the shortcomings as well. Give it two examples that I encounter yearly. For example, is pilgrims pelting. They walk about 1 kilometer to pelt and then return in 48-degree heat about 6 kilometers because of the way that the roads are structured, causing some heat exhaustion. Another example would be the comfort on the 5 days of Hajj. I mean, they'll, for example, be in tents where the humidity, which we've measured, goes up to 65% in the tents because of the basically having high densities of pilgrims in the tents. Aircon's not working very well. And those are the type of things that we can add to the already excellent research facilities that exist already. Thank you.
I think we'll be finishing 10:10, right on time. We have 4 minutes to go.
Yes, just a quick question of one of the suggested questions that we have to Prof. Memish. Within the generous support of the Saudi Arabian government, how do you see the future of the research development and innovations in the global health security and mass gathering?
I think I'm very excited, and I have to say I have not seen such a movement in the country for the last 25 or 30 years when it comes to research. Everybody is working very hard to try to achieve the agenda of the Crown Prince and Vision 2030, where research is going to be the top priority for this country. We have all the resources, we have the money, we have the brains, we have the capacities, but unfortunately in the past we did not have the coordination. And I think now with the presence of IDIA, I think we have all the resources that we need, and also with the Saudi NIH, and they're all working together in one, on one agenda, which is basically to try to increase the research capacity in the country. So I'm very optimistic and very excited, and I think we're on the right path.
Because of the time sake, I'm going to have one comment and question, and feel free to answer, if I may. طبعا, I represent here medical students and other students within the healthcare system, and actually other students within the university. As you know, innovation comes from the intersection of all specialties. For sometimes when we think as medical professionals or healthcare professionals that we can take care of solving a problem related to that. But it's not. Usually it's the engineers, usually it's whatever. I mean, different, the environmentalists, all of them. And my question is, and the talent actually is very important in creating new solutions. And with us sometimes, because we have so many systems and filters in our mind, sometimes we have, certain approaches where the others, they're free to think. So my question is, how do you engage healthcare students, engineering students, and all of them in solving one problem? That's about it. Thank you. Yeah, please.
Very good question, and I think it comes back a bit to the research agenda question and what type of research that we should be doing. Depends who's driving the agenda and how we drive that, and perhaps it needs to be a bit more of a bottom-up approach. And by that I mean we need to ask the people who are attending the events what they think should be researched. Maybe we should be asking students what they think should be researched, or the healthcare professionals at the events what they think should be researched. If you do a bit of a bottom-up approach as well as a top-down approach to developing research agendas, I think that's how you start to engage people in the real-world research that's going to make a difference. So through engagement, I think is important. You can do simple things like small symposiums of bringing people together, having them having real-world experience and then coming back and writing down their ideas. But engaging people, I think, needs to be done strategically to develop the larger questions around your research agenda, and then prioritising year on year about what are the actual questions, and the people with the capability and capacity to answer those questions is the second part to that. So, thank you.
Thank you.
We noticed by observation, I don't know if there is research on that, that the majority of students ask when they want to conduct their research either for undergrad, master degree, or even for board certification, they ask to collaborate with other colleagues for conducting research. I think if we work on this to develop this process and to identify the baseline, how we can make an inter-speciality research, not only on the medical research, medical specialty, with other specialty, we can do that. And I think there is a lot of facilitator for that, hackathons and all other conferences. They ask for any innovation. So in the university, our role is to do that for our students at all levels of degree. Thank you very much.
Thank you so much. It's 10:10, right on time. On your behalf, Prof. Osama, I would like to thank the speakers for excellent presentation and very well experienced and fruitful thoughts after this session. Thank you so much.
Thank you, our valued guest speaker and esteemed moderators. If you allow us for a group photo, please.
Good morning, colleagues. Can you please be seated so that we can start the session? And if Ricardo and Lucia are here, yes, hi, Ricardo, be seated here, please, and Lucia at the end, under your picture. Yes.
Yeah.
Thank you. Please.
Thank you, everyone. Now we are about to start our second morning session, which is about surveillance. I would like to welcome our esteemed moderators, Dr. Adham Abdelmunem and Dr. Sulaiman Al-Ghannam. Dr. Adham, he is a WHO representative, head of mission in Saudi Arabia. Dr. Sulaiman Al-Ghannam, he is the executive director of surveillance at Saudi Public Health Authority. He was the head of population health at the Ministry of National Health Affairs. He has a PhD in population health from the University of Wisconsin with over 80 publications in the area of disease burden in Saudi Arabia. Welcome, and the stage is yours.
Thank you. Thank you so much. And I'm very happy to be introducing this session because I think surveillance is the most important function probably in the detection, monitoring, and response of health threats and emergencies during mass gatherings. And the strategies that it involves really include a wide range of risk assessments, events, syndromic, and environmental surveillances, which are really necessary during events, during the event itself, and the post-event So in the pre-event surveillance, definitely early warning systems is crucial, and maybe Dr. Ahmed Al-Ahmari will highlight that. The event itself, case reporting, rapid response teams, and also data sharing is also crucial for proper decision making and response. And maybe Dr. Ricardo will highlight some of the issues on the World Youth Day, medical preparations, and how we can respond properly during such events. Now, the post-event is also very, very important, the post-event surveillance in monitoring, evaluation, and also in the after-action revisions and documentations for the next cycle of preparations. So I think surveillance is, and I've worked in Iraq and Yemen as representative and head of missions, and I can tell you that this was the most important function during emergencies that I personally took care of, and it helped me a lot in many decisions. Use of technology also is extremely important, and the real-time data, early warning, as I said, big data, artificial intelligence, data-driven decisions, safeguarding and making policies for the individuals, attendees of the event, and the host communities is absolutely crucial. And all of these decisions and policies emanate from surveillance. So without further ado, let me start by introducing our first speaker, Dr. Ahmed Al-Ahmari. Dr. Ahmed is a medical doctor with a wealth of expertise in preventive medicine and public health. He has the Saudi board degree in preventive medicine and a Master of Public Health with a specialization on disaster epidemiology and management. Dr. Ahmari's illustrious career includes serving as a Deputy Director General of the Global Center for Mass Gathering Medicine. So you're from the family of the organizers. But of course, being as he is, his extensive experience and remarkable insights, he sought to even expand his career by serving the WHO Eastern Mediterranean Regional Office, where he's now a technical officer on mass gatherings and working in Cairo. With an exceptional commitment of advancing medical knowledge, Dr. Ahmari has made notable impact in the academic front. He's an author of over 30 scientific articles in peer-reviewed journals. His research contributions have developed into various clinical aspects of preventive maintenance, of preventive medicine, public health, disaster epidemiology, and management. Dr. Al-Ahmari's multifaceted career and dedication to public health is commendable, and I welcome him to the stage to give his first presentation. Thank you, Doctor.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Dr. Adham. Good morning, ladies and gentlemen. Thank you for joining us today at the 5th International Conference of Mass Gathering. I am honored to have the opportunity to speak to you all about health early warning system today. Throughout the history, humanity has faced devastating health threats. From the Black Death in the 14th century to the Spanish flu in the 19th century, this pandemic have claimed countless lives. But if in the modern time, we face significant challenges. Emerging infectious disease like SARS, MERS-CoV, Zika, and the ongoing battle with the COVID-19 are testaments to the ever-present threat of infectious disease on our humanity. With world more connected ever, there is an increased need for constant vigilance. The pattern suggests a rise in frequency and impact of such outbreak make our discussion today is more crucial. In today's interconnected world, emerging infectious disease can travel across the continent in a few hours, overcrowded regions, events, mass gathering events like Hajj, often become hotspot for disease spread. Such system demand a real-time detection and response. As you know, the goal of international health regulation is to prevent, detect, and respond to public health events. Key concepts in achieving this goal based on all hazards include risk assessment, surveillance, and response. Risk assessment answers the questions on what might happen and how likely it's happened. Surveillance answers the questions, how will we know when it happened? Why response, what we will do when it happened. The surveillance evolvement starts since 16th century. Bill of Mortality were weekly mortality statistic in London designed to monitor burial from 1592 to 1819. This is the first data collection ever happened in the history of public health that's organized the data from the dead population. Then, after establishment of WHO in 1948, after 2 decades, the WHO introduced the first definition of the surveillance as a systematic collection and use of epidemiological information for the planning, implementation, and assessment of disease control. After that, CDC Atlanta introduced the first, the definition of surveillance that we are using now as epidemiological surveillance, an ongoing systematic collection, analysis, and interpretation of health essential to planning, implementation, and evaluation of public health practice. The final link in the surveillance chain is the application of this data to prevention and control. Then in 2012, the WHO introduced another definition that includes the early warning system as the first time. Actually, the early warning system as a concept is a crucial part of the IHR, which is called real-time surveillance, targeted strengthening foundational indicator and event-based surveillance system that are able to detect events of significant public health, animal health, and health security. Early warning system generally analyze surveillance information, giving out the timely warning of any sign or abnormality in line with law regulation and relevant provision for emergency plan, allowing for facilitation and ease of making appropriate and corresponding recommendation and action. The main talk today is about our experience in Hajj for introducing health early warning system as a success story. In Hajj, as you know, international pilgrims made around 75% of Hajj population, emphasizing the global. This attendee from around the globe emphasized the global importance of health measures during these events. Disease prevention during Hajj is a critical public health priority, given the vast congregation, the diversity of Hajj. The Hajj is coming from different epidemiological background. This is proposed for enhanced surveillance system for mass gathering. While an electronic platform of health system in Saudi Arabia, monitoring of infectious disease was in place and advanced in technology, but the Saudi Arabia Ministry of Health introduced a more comprehensive health early warning system since 2019 in Hajj season. Let's talk about the journey of health early warning system in Saudi Arabia. The health early warning system in Saudi Arabia started at 2015 for reviewing the surveillance system at mass gathering across the globe. Then in 2016, we do need identification, stakeholder engagement. Stakeholder was from Global Center of Mass Gathering, Field Epidemiology Training, and from the WHO, our colleague in EMRO. Then in 2017, we start piloting syndromic surveillance during Hajj with manual data entry. And in 2018, we start with electronic data collection, and this is based in Mina and Arafat. In 2019 was the first launching of full capacity or full scale health early warning system during Hajj and Riyadh season here in Riyadh, and this is that we will talk about today. At the COVID pandemic, the Ministry of Health decided to expand the scope of health early warning system to cover the whole country. Health early warning system we built in Hajj, it was based on syndromic and event-based surveillance. It has characteristics information-based, based on timely and accurately surveillance data, timeless, actionable, and information actually need to be improved. Health early warning system include elephant syndrome, like acute febrile syndrome with rash, without rash, acute febrile, acute flaccid paralysis, and 7 public health events, including food poisoning, HRI, and CBRNE. Health early warning system get data from 2 main sources. First, from health facility sources and from extra health or non-facility based sources. The health facility sources include demographic and professional diagnosis from the clinician through the health information system. The non-facility system includes social media, internet, and hotline. When the alert coming to the health early warning system from health information system, from National Health Observatory, or from e-links, also from social media, internet, social listening, and hotline direct entry of the data, it's coming to the health early warning system. It's making alert. Then the investigation team, which include 2 epidemiologists, and using artificial intelligence, verifying this notification. And this is appear in Hughes dashboard on the command and control center, either regional command and control center or national command and control system. This is utilizing by event management system to verify this signal and dispatch the team through emergency operation system. This is the dashboard, the first dashboard of health early warning system. Health early warning system during Hajj is utilizing main data from health information system. We consolidated into central database, providing unified information sources. In a publication that published in 2019 by Global Center of Mass Gathering to summarize this experience, we find the following. The consultation rate is total about 500,000 consultation for emergency and outpatient clinics. 3-fold raise in consultation rate during Hajj rites, 80% among pilgrims. Male represented 62% from the consultation, double-fold reduction in consultation from non-pilgrims. Automated alarm during the Hajj period is around 121 automated alarm. Of this, 49 field investigation was happening, 1 alarm generating through the hotline. Daily mean of response was from 2 to 3 hours time. 2 health events were confirmed later. The confirmed event was 2 non-infectious disease, HRI and injury, prompt detection of non-infectious threats, event monitoring epidemiologically by epidemiological triad, who, where, and when. 79% of suspected HRI cases were reported in Mina and Arafat. Actually, during 2019, the health early warning system was operated as near real-time surveillance, which hourly data extraction, which might be inadequate which might be adequate in non-mass gathering events, but during mass gathering it poses challenges during Hajj. Many pilgrims leave their health center within an hour, and hence swift identification of this event is crucial to because the Hajj is not constant place to follow up there. Leveraging the pre-existing surveillance system resources ensure prompt response feedback typically within 6 hours. When we expand the Hughes throughout the country, Hughes operation team responsible for ensuring accuracy and relevance of alert, the team collaborated with Hughes coordinator in all health sector in the regions. The communication is through ticketing system. Hughes coordinating automatically generating the ticketing system and the reply coming from the region or another facilities by ticketing system. By leveraging the power of syndromic surveillance and timely alert generation, the health early warning system empower health stakeholders to detect potential outbreak or health events swiftly. The proactive approach allows for prompt response, resource allocation, and intervention to mitigate the impact of emerging threat. Ultimately, hues play a crucial role in safeguarding public health and strengthening the overall resilience of healthcare system. Continuous disease surveillance should be paired with robust early warning system and response. Mathematical modeling and utilizing of artificial intelligence when used correctly can enhance early warning system. The Saudi experience of health early warning system during international mass gathering, nationwide, and during real season, it underscored its benefit. Future system must learn from the past success and failure to be more effective. In rapidly changing scenario, forecasting and scenario analysis like mathematical modeling might be more effective. Forecasting and scenario analysis might be more effective than precise models that become obsolete quickly. There is a need for continuous improvement in modeling and analytical for better monitoring and intervention. This requires more resources, coordination, and integration of decision-making with academia model. Thank you.
Thank you, Dr. Ahmed. And I was a first-hand witness of this early warning system during the last Hajj with the team from WHO regional office, and it's really pretty impressive. And also, as you mentioned, what's more important than the response is actually the ability to predict, because this definitely helps in reducing the impact of an emergency or a disaster. Our next speaker is Ricardo Mexia. He's going to present the World Youth Day medical preparations. Ricardo is a public health doctor and epidemiologist specializing in infectious disease surveillance. He's currently the president of the Infectious Disease Control Section of the European Public Health Association and works at the Epidemiology Department of the National Health Institute, Dr. Ricardo Jorge Insa. Mexia also holds a medical degree from the new University of Lisboa, a master's in public health from the National School of Public Health, and a healthcare management degree from the Catholic University of Portugal. He teaches public health and preventive medicine at various universities and is currently the president of the Lumiere community in Lisboa. I hope I'm pronouncing the things right. He has also served as the president of various organizations, including the Portuguese Association of Public Health Doctors. We welcome Dr. Ricardo.
Good morning, everyone, and it's a pleasure to be here and share the experience with so many of you. And also I'd like to thank Dr. Anas Khan for a very generous invitation to also share this experience from Portugal. So just a brief introduction on what the World Youth Day is. It's an event for young people organized by the Catholic Church. It started in '85, and it's taking place every 3 years, roughly. So Lisboa was the last destination, but before it took place in Panama, in Krakow, in Rio de Janeiro, and the next event will take place in 2027 in South Korea, in Seoul. Just for context, Portugal is a 10 million population country. The Lisbon area hosts 2.9 million, and the city itself has 450,000 people. So to host an event when 1.5 million is indeed a challenge. I understand that for the kingdom it might be an irregular year, but for us it was a big, big challenge. So I'm going to share the experience we had. There was a previous event, which was in 2017, which was the commemoration of the centennial pilgrimage to Fatima, but it still was fell short, mostly by half of the size of what took place this August in Portugal. So the event takes place over a week, from the 1st to the 6th of August, but it's preceded by several events that took place all over the country. So there was a scattering of the pilgrims from all over the world, and they were involved in activities all throughout the country. And the whole event is also taking place at different venues in the city, with the biggest events taking place in the city center in a big park called Marquês do Pombal, and also at a venue that was specifically created for the event, for the last day of events that was designed to be an event place. So the legacy of this will be to use the setting for future events also in Lisbon. For handling all the health-related matters, the Ministry of Health had decided to create a task force of professionals from the different agencies, the different institutions from the Ministry of Health in Portugal. And it had a mandate to coordinate preparedness and response. Here we have a picture of not all, but several of the members of the task force. So in all, there were 17 institutions, which ranged from the regional health administrations to the drug regulator, to the ones that handled IT, the ones that handled surveillance, the one that handled blood and donor transplants, and also the National Emergency Institute. So it was a quite diverse number of institutions that covered all the health aspects of the response. So prior to the event, there was a significant concern on creating capacity to respond to such an event. And of course, scalability was one of the main issues to be able to deal with a population that was far exceeding the usual demand for healthcare in the Lisbon region. There was a significant concern over public health interventions, such as water and food safety, accommodation facilities, and also for surveillance of several public health threats, such as Legionella. We've had the third largest outbreak of Legionnaire's disease in Portugal in recent years, so that was a concern. And also dealing with vector surveillance, where there's been now a number of vectors that have surfaced in Portugal. There was an increase in the national helpline, so we have a national health service which has, let's say, a front office with a national helpline. So it was capacitated to respond in Portuguese and English, but also through the Authority for Migrations in Portugal. They had also a translation helpline that could handle different languages. The system was also designed to issue temporary NHS numbers so that the pilgrims could access healthcare. It's a universal system, so they could access healthcare in all the different settings. So there was significant concern to scale up both primary care, pre-hospital and hospital response, both in equipment and human resources. And there was a significant concern also for the IT system, because the demand for information at a crucial time as such was vital. So there was effort to increase interoperability from the different apps, but also a development of the app that we currently have for the National Health Service to cater to the needs of the inflowing 1.5 million people. We had the pre-deployment of the emergency medical teams and setting up advanced medical posts, and our EMT are certified Type 1 mobile and Type 1 fixed. And we actually had, as you'll see just forward, there was a WHO mission there also to better understand what was going to happen. Of course, as any operation this size, there was significant civil protection integration, and one of the big concerns from the start was what the legacy would be from this particular event. We faced some challenges. Surprisingly, there was not much data from previous editions. One would think that it would be a report with detailed information, but it was not available. We had a significant uncertainty on the number of participants that could range from 500,000 to 2 million, so there was no real forecast on the number of participants. There was significant logistics demand, so some needs were unable to be catered to only using the national supply, so we had to recruit resources internationally. There was the fact that there were several events taking place in different places also increased the challenge, and the structure being international, national, regional, and local with different challenges for each of them, of course, also posed a significant challenge overall. And to add to this, during the week, we actually had a heat wave, which also increased the issues that one might face at an outdoor event. So we needed to set up surveillance tools, and we used the tools we already had and developed some that were yet unavailable. So we have a system for the surveillance of communicable disease. We have very real-time surveillance of mortality, which is updated every 10 minutes, so you know really in real time how mortality is evolving. We have data from the National Helpline, which enables us to monitor also demand. If there's an increase in the number of calls, we would be able to detect that. Also the emergency line from the National Emergency Institute. And we had different providers on call that could provide us data on whatever occurrences that they were showing up, both at the primary care and also at the hospital level. We also have an information system that's in place already for data on hospital admissions, and that was also monitored during this week. And we also have two systems, one for monitoring the impact of the increased temperature, and another one for lab results, which is independent from the communicable disease surveillance. And here you can see some of the data that we use. So the mortality, the communicable disease information, the impact from the heat on the population, but also the waiting times for the different healthcare settings. But we also used, besides indicator-based, we used event-based surveillance. So there's a weekly bulletin that was updated for a daily issue. There were, of course, different tools to assess what was going to be shared on the media. We used mobile data to know how many people were at each of the places, and that was also very useful to get an estimate on how many people were actually on the ground, as it's an open event, so there's no, let's say, doors to get in. We used data from the Meteorological Institute to monitor the impact of the health, and we used, of course, also the international tools such as the Communicable Disease Threat Report from ECDC and also EWRS and EIS to identify any potential threats that might be relevant for the event in Portugal. What we also did was train the different professionals. So we performed different training activities. All of the hospitals or the primary care had a refreshment on their contingency plans, so they did some exercises on what to do in the event of a mass casualty. But we also trained all the public health staff in mass gatherings. So we have a 2-day course where we share the experience we've had for mass gathering surveillance in particular. And we also had for the emergency response, the medical response to major incidents course that hosted roughly 150 people and that were trained from the different organizations. And there were participants from all of the civil protection that were also a significant added value to this. Communication was also designed to address the potential needs of all the participants, and it was translated into different languages. Recommendations were issued beforehand so that people were aware, even when before leaving their own homes, what to bring and what to take care of. For instance, vaccination recommendations were issued. There was an app that was designed by the event producers we were able to include health information validated by our health communicators to be available to all the pilgrims. And the app actually had an advantage, which they had notifications that were sent on a regular basis to the pilgrims. So this enabled, for instance, during the heat wave, to send across messages that were very relevant at the precise time. And of course, there was a reinforcement on the response from the National Helpline and also on the emergency line. A situation room was created. Bear in mind, this is not the public, the civil protection response. They had their own rooms with all the different civil protection agents. This was for the Ministry of Health, and we had access to, in real time, to the different dashboards. And here you can see the team at work in that particular room, and also the dashboards that were used to monitor the evolving situation. We held also twice daily briefings to make sure that none of the potential problems was missed and that we could intervene in an adequate time. Also, we had international cooperation. So there was both from the pre-hospital care Spanish mission with several professionals that were also sharing their experience but learning from ours. And also there was a WHO mission, as I mentioned, that was also on the ground to see how the EMT that was recently certified was working. So it was very interesting also to learn from the experience from the different experts that came from different settings. To address the different things that we explored during this event. So we felt that integration of data sources was was a requirement that was still at a stage where it was not that useful yet. So for the future, being able to gather the information from the different sources. And I have to share that Portugal has mostly digital IT system. So it's no paper anymore. All medical records are now electronic. So we have a good setting, for instance, to implement syndromic surveillance using the tools that are now being made available. So just a short step away from being able to do so. And this would enable us to have much better evidence-based decisions in real time, which was, during an event, of course, very significant. We would benefit from a clearer organization structure. As I mentioned, we had a national, an international, national, regional, and local organization. And sometimes it was difficult to deal with the different levels. And also, there was the government that was involved. It was the city hall that was involved. So sometimes all the ideas were not exactly aligned. And this also posed some difficulties in implementing the solutions we had, in particular for the health sector. Evaluation is essential, both as hot and cold debriefs, but also as a report. We wish to have a report out. It was supposed to be out by the end of the month, which is today, but unfortunately it's not yet ready. We're looking forward to finish it over the next couple of weeks, so I'm sorry I can't share it today. Also, the purpose of training to enable better response is also on the top of the recommendations list. One thing that sometimes is overlooked is the legal framework, and this was very clear during the COVID-19 pandemic, but also during mass gatherings, it's also become openly clear. And we do have a new recommendation that was issued in May, but it lacks implementation. And of course, this framework needs to be improved as it's just starting now. Also, one of the key aspects that we want to make sure that doesn't happen to the next organizers is having a lot of information available. So the report for us is something that we really want to share with our colleagues at South Korea for their organization. And last but not least, legacy from the event. It's very important to organize the event, but it's also important to what's left behind when all the participants go home. And for us, it was very useful to develop several tools that we hope will also present a significant advantage to the Portuguese population. Thank you so much for the opportunity, and I'll be looking forward to the debate with the panel.
Thank you. Thank you so much, Ricardo. Yet another example of how preparation should be done in preparing for an event. I'll give the floor to my co-moderator, Dr. Suleiman Al-Ghannam, to introduce Riyadh, Carlos, and Lucia. Over to you, Doctor.
Thank you, Dr. Adham. It's my great pleasure to introduce the third speaker of this session, Dr. Riyadh Al-Ghamdi. Dr. Riyadh Al-Ghamdi is a consultant with a Saudi Board of Preventive Medicine, as well as a Master of Public Health from Johns Hopkins Bloomberg School of Public Health. He has over 12 years experience in the public health system of the kingdom, including roles in planning, executing, monitoring, and evaluating for public health programs. He has served as the Deputy CEO for Public Health Authority, Wiqaya, and had led strategic planning implementations for 2019 up to 2025, inshallah. Relevant to this work, to this talk, Dr. Riyadh has also led the National Health Security Strategy Project, focusing on aligning health security with national security strategy, identifying national initiative to address health security threat. So without any further ado, stage is yours, Dr. Riyad.
Thank you, Dr. Sulaiman. Good morning, everyone. I'm very glad to be with you today as public health leaders and professionals in the kingdom and all over the world, and I hope I will add some value for the audience. So I'll be speaking about the integrating systems to achieve global health security from local perspective to global perspective. I will talk about certain items in the presentation. Maybe most of them are, you already heard them during the course of these 3 days. However, I will reiterate some of them because the most important thing in my experience, how to bring everyone in the national level to believe in integrating these systems and also to support it. So surveillance defined as the continuous and systematic collection, orderly consolidation, and evaluation of pertinent data with prompt dissemination of results to those who need to know, particularly those who are in position to take action. And I think the value chain of surveillance system should focus more and more as public health professionals on those people who can take action, because those people who can provide us with the means and resources to build the system in the first place. And I think as a public health system, we are not very well, let's say, involved or let's say invested in making the case for decision makers from healthcare system, but also from non-healthcare system. Key elements of any surveillance data is collecting health data for health planning, disease control and prevention, and also provide timely analysis, dissemination of the results, informing discussions, and active evaluation of the system. Surveillance gives more clarity on what's actually happening, understanding natural history and estimating the magnitude of the problem, detect pandemics, generate hypotheses, and stimulate research, which is a very important element on the long-term to achieve our long-term goals of public health, exploring changes in pattern with time, understanding and monitoring the disease characteristics, measuring the effectiveness of public health interventions and control measures, and also forecasting trends. There are primarily 2 types of public health surveillance, as all of you know, the passive and active. And historically, the term integration started when we started to do an active surveillance, because integration as a concept is evolving over time. Previously, it was the passive surveillance system is the main way of collecting the data, where healthcare workers and providers send reports to the public health departments on the basis of known set of rules and regulations. It is inexpensive, provider-initiated, good for monitoring large number of typical health events. And also, it is very good to give you a historical background of all the problems that you are monitoring. However, the active part, which is the public health department or public health authorities usually will approach the health providers and non-health providers actually, usually limited to specific diseases over a limited period of time, such as after community exposure or during an outbreak. And the integration part of this, where the decision-making started to be an integral part of the data collection. In the passive type, usually decision-making are delayed and not usually, maybe not ever implemented. We have different approaches in surveillance: event-based surveillance, indicator-based surveillance. In the event one, the organized collection, monitoring, assessment, and interpretation of merely unstructured ad hoc information regarding health events or risks which may represent an acute risk to human health. Indicator-based surveillance is a component of the early warning, alert, and response function of a national surveillance system. Integrated surveillance system ensure the integration of human, animal, and environmental surveillance systems for a proper sharing of information across different stakeholders at multi-levels. It recognizes the health of humans, domestic and wild animals, plants, and the wider environment, including ecosystems, are closely linked and interdependent. And here exactly what we mean when we say we need a wider support from decision makers in health and non-health systems to believe in the value of integrated surveillance system and provide the concept for them that they will have huge return of investments on this money that they will put based on the outcomes that will inform the decision-making process. Using available electronic health data by linking digital registers and databases from health and non-health sectors. For example, you can utilize the environmental ecosystem surveillance system to integrate it with the emergency health surveillance system, just to understand the impact of a stormy day on the asthmatic patients. So to collect those two together and link it to a decision-making process, it is not only a digital solution. It is a full integration between two systems. They don't understand each other. They don't know each other. However, building the integration as a full system between the two leaders on the system, also the different management layers of the systems will enable us to provide the value for both of the systems. Eventually, we are protecting our population. It is our children, our people. It's not a sectoral thing. Key mechanism for integrated surveillance system, and that's very important to be understood as early as possible, because here in Saudi Arabia, and I think it's all over the world, digitization and digitalization are coming in all and everything. Understanding the importance of interconnectivity between these platforms and these data variables are very crucial, just to save us a lot of time and a lot of money, just to start over again and again with introduction of each new digital system. Also, the interoperability and semantic consistency regarding how the interpretation of these data variables to be understood by different players in the integrated surveillance system. So the importance of integrated surveillance, as I mentioned before, policy making and planning, clarity on burden of disease, mortality, morbidity, and cost, direct resources mobilization, and enhanced evidence-based decision making. Monitoring and evaluation, that will give us the ability to measure the impact of diseases and public health interventions. Maybe public health interventions here are more relevant to our understanding of how policymakers should be involved, because sometimes you'll ask a lot of money to intervene in certain circumstances, and we cannot provide the value of these interventions or the impact of these interventions. And that with time will give us a very hard time to reinvest or to ask for more support. Identifying the linkage of certain diseases or events and other non-health variables, and also will help the countries to have a better preparedness and response plans. What happened internally in any nation is happening between nations. So the same problems you will face in the national level, between sectors and between different players, it's happening between global players. And as you understand, as a public health professional and global health professional, that diseases are not recognizing our boundaries. They are traveling all over the place. So I think all the resources and information and decision-making, let's say, support ideas, we need to invest not only in the local and national level, but also to develop an agreement or understanding on the global level that country leaders and country minister of health and countries who are sharing with us all these risks to exchange data in real time, and also to provide them with reassurances that these data will not be utilized against the national interest. So global health security involves developing, enhancing, and strengthening the capacity to protect the health of people and the public around the world. With the acceleration of the global trade and travel, any infectious disease can spread around the world within a span of days. International boundaries became porous to facilitate new infectious diseases. The core aspect of global health security is public health preparedness based on prevention, early detection, and response. And as you understand, WHO and multiple intergovernmental agencies in the world are working together now to make sure that we can, as a global level, having a platform or a venue that we can exchange data between countries to protect the global health in large scale. But the same problems and the same misunderstanding or the same challenges is happening between countries, and these concerns should be addressed in a timely manner, just to make sure that as a nation, internally, between sector, and also as a part of the global community, we have the means and also the venues to discuss these concerns. For example, one-hand surveillance is a very important concept, seeks to detect potential or existing risks that originate at the human-animal environment interface. So on each country have their own system or their own political context. Here in Saudi Arabia, the health system is totally independent from environmental system and animal system. We are working together through multiple committees and multiple organizations to make sure that we have an exchange of data. The challenges that we are facing that sometimes these systems should take care of their own actions before they sharing the data. Making sure that we have a venue, shared venue on the national level where actions or decision-making or even data will be disseminated after approval of all stakeholders and all parties will ensure this system to be integrated as early as possible, just to make sure that we are facing these threats as early as possible. Now, in the era of AI, I think if we overcome the obstacles of integration from, let's say, system point of view or IT point of view, but also from, let's say, decision-making point of view and policymakers, I think the future for public health will be very brilliant because these tools, the AI tools, can analyze and interpret these data and predict very soon. The action that we should do based on this information is also, and again, we'll go back to the decision makers. So preparing the decision makers, making sure that they understand the potential positive impact of having an integrated system in the country is very important to make sure that we are going to utilize the full potential of artificial intelligence for the sake of our nation. So these are just a consideration for public health leaders, and I think every public health professional as a leader is to make sure that we are not selling the idea of integrated platforms and IT solutions, because these are not working. I think we have to invest more in integrating the full ecosystem, including the decision makers, also the policy and regulation between these ecosystems, and reaching to the IT solutions, because that will enable everyone to share these data and make sure we can utilize the information from this data to design and implement and evaluate and monitoring these public health interventions. For example, here in Saudi Arabia, we have a huge ambition to build an integrated surveillance system based on our already successful stories. If you just speak with, for example, Ministry of Education, they are building a very good system to collect injury information from schools. So these type of systems is very important source of information for us in public health ecosystem to just predict and also to improve the situation. Having this information shared with us is not an easy task, because how we can utilize this data? Are we going to publish that our schools are risky, or are we going to just work with the decision makers to improve the situation? These type of concerns, if we address them, I think the IT solutions and the integration in the platform will be much, much easier. And the aspiration that I have for Saudi Arabia, but also for public health ecosystem all over the world, that overcoming these barriers are easier because of the COVID-19. And as you can see, no one country had their efforts during the COVID-19 led by public health sector or health sector. It was led by the whole of government approach, and I think we have to seek the opportunity to build on this momentum post-COVID-19 and provide the value that we can add to the country, to the nation, not for the health only, and build on that to build better systems from collecting the data, interpreting the data, and also make it happen on the ground. Thank you.
Thank you very much, Dr. Riyad, for this very enlightening presentations. I really enjoyed it, and certainly highlighting the importance of One Health and big data and AI is going to be playing a big role in the upcoming years, and I really hope this is taken into account with the recommendation of the conference. My pleasure to present our fourth speaker of the session, Dr. Carlos Franks, who's a medical doctor, an infectious disease specialist with Master in Advanced Studies in Humanitarian Actions from the University of Geneva. Specialized in the field of epidemiology, he has over a decade of experience as a general practitioner, infectious disease, and he serves as a technical advisor for the public health emergency of the Ministry of Health in Brazil. His background includes critical roles supporting management of public health emergency such as the pediatric unknown case and MPOX. He was instrumental contributing the establishing of national surveillance for emerging and re-emerging pathogen in wastewater, and actively participated in structuring national syndromic surveillance pilot project. His leadership extend for management of Technical Advisory Chamber of Ministry of Health, focusing on assessing technical and scientific element crucial for public prevention and preparation for public health emergency. So he'll be talking about surveillance and sport events, and topic is very much dear to many of the attendees and in the kingdom as well. So without any further ado, the floor is yours, Dr.
So, thank you, ladies and gentlemen, esteemed guests. I want to begin expressing that it's a privilege to be here and to discuss this important topic of the immense relevance to our societies. These matters gathering events, whether they are concerts, sports events, or cultural festivals, present unique challenges and opportunities. Thanks, Dr. Anas Khan, for inviting Brazil for this magnificent conference and to be part of these important discussions. I want to start talking about a recent history in Brazil. We have played the host to an impressive array of mass gathering events. We can mention Rio +20, X Games, FIFA Confederations Cup, FIFA World Cup, Olympics, and they serve as examples of the magnitude of this coordination required for these mass events. I will utilize our experience in the 2014 World Cup as a background to discuss a little bit more about health surveillance in sports events. To start, it's important, and in order also to enrich the discussion, I think it's important to contextualize a bit more about our health system and our Brazilian surveillance structure. We have a unified health system, which is a public-funded health system providing free health care to all Brazilians, and provide also universal access, ensuring that regardless their socioeconomic status, they have also access to the medical care. And it is also characterized by a decentralized structure with clear responsibilities among federal, state, and municipal levels, and also offer a comprehensive service from the primary healthcare to high complexity medicine. In the context of this decentralized public health system, the Department of Public Health Emergencies is responsible to manage not just the public health emergencies per se, but also the health surveillance during the mass gathering events. This department is inside the Secretariat of Health Surveillance, which is inside the MOH. And this department is funded in 3 pillars, which orient all the activities and summarize all the preparation strategy for the mass gathering events: preparedness, surveillance, and response. Preparedness, we can say that among all the things we can mention development of plans, guidelines, training, simulations, acquisition of strategic materials. For surveillance, early detection of epidemiological changing of the epidemiological patterns or systematic monitoring and evaluation. For response, we can mention the development of management strategies for minimizing risk, reducing damage, and given the mentioned decentralized management of the unified health system, this tripartite, I would say, it was established, this tripartite model, it was established then a national health chamber, thematic chamber. Moving back to the example of the World Cup, how could be put everybody at the table to talk and discuss about preparedness for this huge event. So this National Health Chamber was a fundamental, vital to ensure a cohesive and a well-coordinated approach to address all the aspects regarding the health sector. And I must confess that Brazil was a kind of war disputing which city was going to host the matches. We have 26 states and the federal district. And finally, after lots of discussion, 12 cities were selected, involving 11 states and the federal district. But as you can see in the map, some places were in completely different regions, bringing significant challenges. I can mention, for example, the climate variations. In the north, we have a tropical rainforest, Amazon climate with lot of rain, high temperature, high most humidity. And in the south, for example, we have temperate climate. So just about climate, but we have epidemiological differences. In the north, we have malaria, for example. In the south, we don't have malaria, but we have dengue fever. And not to mention the logistical complexities. The capital of the Amazon, we don't have access, road access, just by plane or boat. So this is a few of the examples of the challenges to organize such an event. And here are some key initiatives taken during the preparation phase. We organized health thematic committees, 14, to address public health safety, medical response, and others. And also we focus on publication of official legislation to facilitate the process of preparation. Also, we develop and update our contingency plans for different areas, and simulations and trainings, and then, of course, observational learning in Vancouver, in South Africa, also in London. And in order to understand our capacity at that time, it was utilized the WHO Mass Gathering Toolkit, encompassing 10 preparedness components. The idea is not to go to all these components, but to mention a few of them, because it was fundamental to understand our capacities at that time. And we have made an assessment, and I was based on this key elements, and I must confess that it was a bit yellow at the first time, with a lot of work to do. And, but in less than a year, we managed to improve significantly our indicators. The first assessment was made in 2013, and the second 2014, 2 months before the event started. And that chamber that could discuss and bring everybody together at the table was fundamental to improve these indicators among all the 11 states and the federal district. And moving forward, after all this conversation led to development of action plan, which addressed several key areas such as provision and organization in another structure, another body, an integrated center for joint health operations. One was for preparedness and to make the country ready to receive the event. Another, this integrated center was to manage the event, the surveillance and response. And this action plan organized the command and control, clarifying the structure, phases of operation, levels of operation, colors, indicating the emergency level, resources available. And also, it was conceived in one center, national center, to receive all the data, and 12 regional centers involving more than 1,500 professionals. The idea was we have to understand we have different regions with different realities, different kind of data, different epidemiology. So this regional center were fundamental to feed the national center with relevant information. And of course, all the centers were integrated with the organization of the event. And the health surveillance and assistance actions were strategically executed in various key locations arenas, official hotels, surroundings, fan fests, other parties. We know Brazilians love parties, so we have lots of them. Template training sites and tourist sites, and all this data were standardized. All the medical data were standardized, and utilized tablets and other devices to have facilitate real-time data entry. And all data was collected in visualized and online dashboards. Here we are talking about almost 10 years ago. So it was a bit challenging for us at that time to moving forward to this kind of method. And the active surveillance involved not just the medical data, but also health inspections and surveillance in water quality, health services, food safety, vector control, venomous animals, monitoring accidents, and others. And with all this data, 4 distinct modalities of daily reports were produced. First, in the day of the matches, for example, we have a preliminary daily report providing early insights of the day, a final daily report, comprehensive summary of day activities. Also, we have a regional report focusing on regional perspectives, and a special report to the president, an overview of the day with strategic insights. And some statistics to share with you. We had more than 5,500 individuals receive medical care. The profile of the patients were male workers, comprising more than 52% of the medical assistants, and were conducted before the matches. The service rate was 0.16%. It was a fraction with a total paying public of 3.4 million the public, and it was significantly low, this service rate, and just 100 patients were removed from the arenas or surroundings to the referred hospital. The resolution rate was 97.8%, and no deaths were reported during that period. And I want to talk a little bit more about participatory surveillance. That was an innovative approach introduced for the first time during a mass gathering event globally. This is one software called Saúde na Copa. This is translated like health during the World Cup, but the name was not so creative, but the software or the app, it was pretty interesting. We got some robust participation for that time. And the idea was the person could self-refer what are the feeling or what are the state of health, like very good, good, very, or very bad, and post what symptoms the person was feeling at that time. And we got a total of more than 47,000 posts, and all of these posts, around 11% have some symptoms categorized bad or very bad, and this kind of symptoms that the person could choose, we reunite in syndromes. And the most prevalent syndromes were respiratory syndrome, diarrheal syndrome, and exanthema syndrome. The idea was to get these symptoms and to get the geolocalization of the post to understand better which region had the most prevalent syndrome at that time, to plan and to organize the response. So moving to the final considerations, the 2014 FIFA World Cup was still the largest mass gathering event in Brazil history. The plan and the health actions proved to be effective, resulting in no significant public health events. As a legacy, we can mention the adoption of a new disease detection technologies and the organization of the pre-hospital care for mass gathering events. These were remarkable. We understand there were potential for even greater health legacy. Emphasis needed on health prevention and promotion. Also, it's important to mention that in our experience in this participatory surveillance, this model followed tailored to the specifics of the Brazilian surveillance system. It's essential to learn that from this experience, when creating new mechanisms for early detection of public health emergencies, we have to understand, especially considering that the future World Cups, for example, will be hosted in multiple countries. And there can be significant variations in these countries in health surveillance and notification systems. So this is a challenge for the future. And as a last message, we believe that the future of health surveillance lies in continuously enhancing the epidemic intelligence within the surveillance routine. This is important. Gathering data from various sources is the key. From, as a previous colleague mentioned, event-based surveillance, traditional surveillance, wastewater surveillance, genomic surveillance, and syndromic surveillance. Efficient surveillance at mass gathering events must involve multiple sources of information to be sensitive enough for early detection of potential public health emergencies. Brazil is still willing to share its experience than more than a decade in mass gathering. Thank you very much.
Thank you very much, Doctor. Very impressive work on the active surveillance. Really, I think the experience of the World Cup would certainly be an example, especially that sports and major events are of great interest to the region and specifically to Saudi in the upcoming years. Now we'll move on to the fifth speaker. It's my absolute pleasure to welcome another affiliate of Hopkins, myself, so three of us in the room, go blue. Ms. Lucia Mullen. Ms. Mullen is an associate scholar at Johns Hopkins Center for Health Security and Bloomberg School of Public Health, member of the World Health Organization Novel Coronavirus 19 Mass Gathering Expert Group, and a member of the International Olympic Committee. She focuses on outbreak preparedness and response effort, collaborating with WHO, UN agencies to improve health resilience. She's going to be talking about global dashboard, very important topic, and certainly look forward. The floor is yours.
Good morning, everyone, and thank you to the moderators for that wonderful introduction, and to Dr. Anas Khan and his team for a fantastic conference so far. Again, I know I'm the one standing between you all and lunch, so I promise I won't keep you too long. We've heard a lot from my other speakers about different surveillance efforts ongoing within mass gatherings, particularly the health events and how they're collected and reported during a mass gathering. I'd actually like to zoom us out a bit and look more at mass gatherings as a whole and some of the data collection efforts we're doing across the board there. So I'm going to spend the next 10-ish minutes discussing an effort that WHO and the Johns Hopkins Center for Health Security undertook during the pandemic, tracking the type and status of mass gatherings occurring around the world and how we were able to use this data. So as I mentioned, this was a collaborative effort that started early in 2020 and it evolved over time. It started with a request from WHO to map the mass gatherings occurring within the next 3 to 4 months. Again, this was Q1 of 2020. Ultimately, what we wanted to understand was how decisions were being made to postpone, modify, or cancel mass gatherings, particularly in the early stages of the pandemic when there were stark differences in case counts between countries, as well as differences in national policies in terms of lockdowns, border closures, and gathering limitations, and so forth. The data for this dashboard was collected through 3 avenues. Most of this data, we undertook weekly open Google searches for announcements on mass gatherings and their statuses. We also did direct searches on event organization websites. We then sent regular requests to sporting organizations and religious leaders to provide information on national and international gatherings that they had planned for the year. And we engaged with the WHO regional offices, who in turn engaged with the country offices to provide lists of events that were occurring within their region. The data we collected for this dashboard included mass gathering type. So we classified this as sporting, political, business, health campaigns, entertainment, cultural, and religious or faith-based events. The event dates and geographical location, classified as both WHO region and country, the expected size of the gathering, the setting, whether it was indoors, outdoors, hybrid, or virtual, the type of participants expected, international, regional, or national attendees, the overall status of the event, as in, was the event going forward with no changes? Was it cancelled or postponed? Or was it modified with additional COVID-19 mitigation measures? And any reports on whether a risk-based assessment or other risk-based approach was used in the planning of the event, particularly if decisions were made to postpone, cancel, or significantly modify the event due to the risk of COVID-19 spread. For sporting events, we also noted whether the events were team-based or individual, or a combination of both, and whether the sport was contact or non-contact based. Now, before I actually get into the results and some of the analysis we did with this dashboard, I do want to acknowledge that there were quite a few limitations, particularly in the selection bias of the data collection. While the team did do searches in a couple different languages, the vast majority of searches were done in English, so this led to the dashboard being heavily skewed towards events occurring in both North America and Europe. Similarly, as most of our results came from open source searches, often local, small, or one-off gatherings were not picked up if they didn't have a high web presence. Going into some of the results from the dashboard, monthly analysis would be done to monitor trends in data collection, particularly the status of the event and whether these events were using a risk-based approach for any of their decision-making. As of October of this year, there were 5,855 events that were recorded in the dashboard. You can see the breakdown in Figure A of the events by type. The majority of these events were identified as sporting events, followed by entertainment events, which often included different types of festivals. We had very limited data on religious events, as many of the smaller and local events didn't have a high web presence, so we do know that this event, or this type of event in particular, was severely underrepresented in the dashboard. Figures B and C show the percent of mass gatherings that used a risk assessment or some form of risk-based approach by event type and WHO region, respectively. I will say, though, that our threshold to consider what a risk-based approach was very low, as many events didn't clearly say whether they were using a risk assessment for their planning and decision-making processes, so we had to often infer this from some of their rationales. So, for example, if an event often cited the risk of SARS-CoV-2 transmission to its participants or spectators, and it mentioned the level or the lack of capacity in the local health systems to diagnose, treat, and otherwise manage patients with COVID-19, we would have considered this using a risk-based approach. Health campaigns, more often than not, recorded using a risk assessment or risk-based approach during the decision-making process, while religious events often didn't report using such a process. We also didn't see much variation between the regions on whether a risk assessment or risk-based process was used, but Afro was the region that was least likely to report using such a process. Looking at sporting mass gatherings in particular, we didn't see much variation in the use of a risk-based approach for decision-making between events that had individual sports, team sports, or a mixture of both. This is what you can see in Figure A. However, Figure B shows that sports that were contact-based and non-contact were often more likely to report a risk-based approach rather than events that had a mixture of both. And then when we looked at some of the religious events in details, there was fairly even distribution of such events occurring across the WHO regions, but CIERO did report the most religious or faith-based events to the dashboard. And Figure B shows that the status of the event planning. So again, because we had very limited information, most of these events had to go under unknown status, which is that very dark blue line you're seeing. Otherwise, the most popular one was otherwise modified, and this we saw regularly occurring in 21 and 2022. Now, speaking of temporal trends, one of the key trends we saw in the dashboard was the status of mass gatherings through 3 phases of the pandemic. Figure A shows this temporal overview of the global COVID-19 cases and deaths reported to WHO from 2020 to July of 2023. Figure B shows the status of the mass gatherings in the dashboard, i.e., whether they were cancelled, postponed, made virtual, otherwise modified, or held with no modifications. We were able to identify 3 broad phases throughout the pandemic, predominantly cancellation or postponement of events in 2020, modification of events from 2021 to mid-2022, and then events occurring with no modifications from 2022 onwards. As expected, these trends do follow to a large extent the stringency of public health and governmental policies across the same period of time, as well as the evolution of the pandemic in general, and the development and accessibility to various public health countermeasures. So, in other words, there were many movement and gathering restrictions early in the pandemic when we saw a lot of the cancellations and postponements. We did see a gradual move of easing restrictions, as well as ready access to testing, regular mask use, vaccinations, and this is when we saw a lot of events going ahead with modifications of some sort. And then as we've seen more and more countries return to normal, we've seen events going ahead with what we would consider no additional modifications that are COVID-19 specific. Now, while those findings from the dashboard were packaged and sent on a monthly basis to WHO leadership and also helped inform the WHO COVID-19 Strategic Preparedness and Response Plan Monitoring and Evaluation Framework, we were able to find other uses for the dashboard as time went on. So one of those was repurposing the data to become part of the WHO COVID-19 Situations of Concern effort. For this activity, a weekly list was provided of about 4 to 8 events that were expected to occur in the next 4 to 6 weeks that may be a concern for amplifying the spread of COVID-19 due to a variety of reasons, which may have just been a surge in cases in a particular country or region, a new variant or a variant that is surging in prevalence, limited planning for the event, and so forth. So this allowed WHO to provide additional engagement directly to certain event organizers and countries and able to offer targeted support to them. So for this analysis, which is essentially what this figure here is showing you, is we had 2 separate analyses that were occurring in parallel. First, an analysis was done to determine which countries were reporting surges to COVID-19 cases and deaths. The dashboard was then filtered to identify events that were occurring in these specific countries during the time period of interest. At the same time, the dashboard was also filtered for events that were occurring in the time period of interest, but were considered very high profile, had large international engagement, and could be considered high risk in light of the increasing cases in various regions. A list of these events were combined together and sent to the WHO regions for validation before they were shared as the finalized situations of concern on a weekly basis with WHO. When the Mpox outbreak began, the dashboard was able to be repurposed yet again and used in a similar way to generate a list of events that may require additional support in light of this ongoing outbreak. So the process was very similar to what we'd set up for the COVID-19 situations of concern, but we did add in additional step where we analyzed the events themselves for their relevance to Mpox. So for example, if an event popped up that was more of a business conference or a much smaller event, it wasn't necessarily considered a high risk versus entertainment events such as festivals that often include increased risk factors. So this helped us filter our list of events even further. Now, looking forward, despite the limitations in data collection, this dashboard in general did show the benefit of tracking mass gatherings at a bird's eye view and the decision-making that were occurring around the planning and hosting of such events. This, we do recognize, was a very rudimentary effort of hosting such events, especially with a limited data collection scope. However, it has provided the foundations of what we believe we should be tracking and sharing within our mass gathering community, which could include event organizers, public health authorities from various governments, and of course, the mass gathering experts and international organizations. Expanding this effort to have more regular and standardized reporting would be beneficial and provide opportunities to increase engagement within or between event organizers, national authorities, and all these other relevant stakeholders, so that we can actually share lessons learned and experiences, we can improve follow-up with conducting after-action reviews and legacy reporting, and we can enhance engagement across multiple stakeholders who could refer to and utilize the data collected in such a dashboard. We understand that most of this data is readily available. Our problem is it's spread across numerous different platforms or search engines. Putting it all together in one place has proved beneficial. And in review, we do believe such a global platform could be used to share information easily between event types as well as sectors, therefore enhancing our general mass gathering planning. And we'd love to see how we could continue these efforts in a much wider initiative beyond COVID-19. Thank you very much.
Thank you, Ms. Mullen. Very insightful and really helpful to see how the dashboard could be used for future surveillance systems. My colleague and I have some questions, but we don't want to hog the stage, so we'll open the floor for the audience, for anybody who has a question to our esteemed panel. In the back.
Assalamu alaikum, Zaid Al-Mayahi, USCDC Regional Office from Muscat. This is actually a great session highlighting the importance of event-based surveillance, which actually provides a solution for the limitation of the indicator-based surveillance. As you know, we get sometimes delayed detection of cases, and for other limitations, we all agree about the indicator-based surveillance. Indeed, I'm also thinking like the event-based surveillance should always be expanded as an umbrella so that it can also get the signals from the waste surveillance, wastewater surveillance from the previous discussion we had. It can also expand of getting the signals, the unstructured data from the points of interest, and that would always strengthen the event-based surveillance. We can always think about this as a constant surveillance system, but certainly it is a necessity during mass gathering with the unique experience in Saudi Arabia, for instance. The other part of the comment or question here, we also understand that the mechanism of event-based surveillance of scanning the media and getting information locally or overseas, which is really great because this can precede the information shared through the IHR sometimes for reason or another. But I'm also asking the distinguished speakers here, are you thinking that establishing a cross-border surveillance between countries would also complement the role of IHR in getting the information as soon as possible? And the question is, we think about cross-border surveillance as perhaps a constant system, this is one, or we could also utilize it as one tool during mass gathering events. Thank you very much.
Thank you. Any of our colleagues?
Thank you so much for the question. I fully agree that there's a significant role for event-based surveillance, and there are plenty of options out there that we can explore, such as wastewater. Participatory surveillance is a big potential because you can detect things before people actually look for healthcare. I mean, there's a significant amount of things you can do. But concerning cross-border, this is particularly relevant for Europeans, as borders are much non-existent in traveling. And I can recall that we had an event in Portugal where we had a festival where patients were already coming sick from another festival. And sometimes there's like a tour of people that visit different events. And therefore, we were unable, because there was no previous setup for that, to connect with the people who were doing surveillance for the other festival, which was in Spain. So I think that could be very interesting. It also connects with what Lucia was saying, that we should have more standardized data collection that would enable much more interoperability and exchange of information between the different countries and settings. So I fully agree with what you commented.
Thank you. Thank you, Carlos. Thank you, our colleague from CDC. Two very small points to complement your answer, Ricardo. First, about the media reports. I was the head of WHO mission during Hajj this year, and we've been receiving media reports. My colleagues are here, and not 100% of them are accurate. Sometimes there is false reports, exaggerations, and what we did, and I think this is maybe something that I really would like to recommend to any mass gathering committees that are involved in planning and command and control, is before creating the panic of media reportings on a larger scale, we have to investigate. And we have to give time for investigation. And I think the window for us that we've taken was 4 hours with our regional office and headquarters before trying to get the reports out. And I can safely tell you that we've received maybe 2 or 3 reports. All of them turned out to be not true. So that's one. But it's important to scan the media, as you mentioned. And the second point is also around sharing the cross-border surveillance data. Definitely it's useful and it's beneficial to the IHR work that is ongoing now between countries, and that's something, and Saudi Arabia is very much active on this part at the global level as well in Geneva with the new IHR regulation coming out soon. So thank you for pointing those two. Back to you, Dr. Sullivan.
Any other question from the audience? Okay, go ahead.
Okay, thank you for very useful session. I noticed in 2 of the presentations, I think from Dr. Ricardo and Dr. Riyad, they mentioned about a legal framework for the surveillance system during the event. Can you shed light on that, please? Because prior, of course, there is a legal framework. There is a Ministry of Health, for example, responsible for coordinating the surveillance. Why is the need to create a new legal framework for the event itself? Thank you.
Thank you. I think it's very important to understand the implications of collecting data and, making decisions based on this data. And usually these decisions will impact certain liberties of people, certain data privacy. It's very hard to just convince people by the value and the importance of surveillance systems, just in case they will understand. Sometimes you have to have the legal framework from the jurisdiction of each country. In our case, in Saudi Arabia, we have the health law and the bylaws of the health law, and it's undergoing revision and transformation. And I think surveillance is a very strong pillar for the health system to have its roots in the legal code of the country. That will enable us to ask for more resources and also for easiness of the implementation of the decision-making that we intend to do. I think all the presentations today, I noticed that during the management of any event, you'll have all sectors together. And maybe what we saw today is mainly about health, operation room, and health decision-making, but I think that's linked to a higher place where maybe the city hall or the governor or a higher authority that they can make the shots and making the decisions. And usually, if you have a framework, legal framework to support whatever you are recommending on legal basis, that will facilitate how health sector will influence the decision-making process. Otherwise, sometimes you have difficulty to collect the data itself because people will say you don't have the right to collect the data. And from our experience during the COVID-19, we utilized the highest authority in the kingdom to generate decisions just to facilitate sampling, to facilitate collecting of the data, making sure that these decisions are not delayed because people should understand or they understand the value. So during emergency and during response, you will find the value of having a legal framework that will facilitate the work and the implementation. And going forward, I think the legal framework will have a huge implication, not only during the event management or during the response, but also how we are touching the civil liberties, how we are making sure that people are following the guideline different level. For example, vaccine hesitancy. These things are deeply rooted in public health literature, and maybe that's an area that we have to put more investments in as public health professionals. Thank you.
No, I fully agree with what Dr. Al-Ghamdi just said. So I'll just add a small detail. Because of course we faced significant challenges with legal framework during COVID for containment purposes, for isolation purposes. This was, I guess, a problem everywhere. And for festivals or events, it's also an issue because you don't have a framework to say, okay, you have a communicable disease, you shouldn't be here, so how do we keep you out of the event? So this is just an example of something that might be very useful for events, for mass gatherings. But just on a more broad scale and not in an extreme scenario as this, often we wouldn't have data about any of the mass gatherings. We wouldn't know what health issues were occurring at those events. And for Portugal, since May, we now have a new regulation that makes it compulsory for who's producing an event to actually have records on what's happening from a health point of view. And that will enable us, on one hand, to early detect eventual problems, but also to have data for future risk assessments. When I want to license a future event, I'll have the history from the previous editions to either impose restrictions or better design, for instance, the healthcare support that the event might need. So this, over time, we're looking forward to have much more data to actually have more evidence-based decision with the information that we gather.
Thank you, Dr. Ricardo. I could listen for this for hours. I think I could gladly say this is one of the best sessions I've heard this year. Diverse, rich experience across the world, but unfortunately it has to come to an end. So I would like to take this opportunity to thank our esteemed speakers and my colleague, Dr. Adham, and really thank you for attending from our colleagues. Thank you very much.
Thank you, our valued guest speaker and esteemed moderators. If you allow us, that we will have a group photo, please.
even help you digest what we have learned up until now. As we all know, immunization is an important item in any global health security agenda. Health authorities have the burden of validating and choosing which vaccines to approve, handle the access and logistics for vaccination programs and campaigns, and raise awareness within their respected public. As we have seen with the COVID-19 pandemic, it is essential to invest in the development, manufacturing, and distribution of vaccines. The implementation of the previous points would contribute in enhanced global health security, especially during mass gatherings, as vaccines would help with protecting attendees from vaccine-preventable diseases, and would cut out and reduce disease transmission. In short, vaccines contribute to overall health, safety, and livelihood. We would like to welcome our esteemed guests for today. We have with us Dr. Khalid Abdul Karim. Also, we have with us Dr. Salim Parker, and Dr. Anwar Hashim, Dr. Haroon al-Rashid, and Dr. Halim al-Sirahi. We would like to invite our first speaker to the podium, Dr. Khalid Abdul Karim. Dr. Khalid Abdul Karim is the Assistant Deputy Minister for Healthcare. He has held various positions, including the National Lead for Enhancement of Primary Care and the Chairman of its Central Hub. Also, the National Lead for the COVID vaccination, mass testing, and fever clinics programs. Dr. Abdul Karim holds an MBA in International Healthcare Management, a fellowship training in diabetes from the Medical Royal College of General Physicians, and he also has the Arab Board and Saudi Board in Family Medicine. So please welcome Dr. Khalid with his speech today.
السلام عليكم ورحمة الله. بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء والمرسلين. Thank you for having me today at the Mass Gathering Conference, and thank you for your time. And I hope that I can give you an idea about what happened during the pandemic and the COVID-19 vaccination. I believe this is a learning experience that we can exchange. I hope we don't need to use it in future for any pandemic, but it is as an operation or a huge operation or mass operation, it might be helpful. So talking about the vaccination program in Saudi Arabia, it was well known that the Kingdom of Saudi Arabia had reached the target of the immunization of the community within remarkable time, and we spared our health system and the community from the complication and the devastating complication of COVID-19. Kingdom of Saudi Arabia was one of the first countries started the vaccination program. Just Canada, UK, and United States, they started before us. We started on 2020, and planning such a program was very important to keep this program ongoing. It lasts more than 1 year, and it had to be monitored very well in close, and the work had to be well organized. We started with very clear goals. Our main target was the coverage. We want to start with the high priority groups, those vulnerable and might have complication when they get the infection. The other target is to reach as soon as possible 70% of the population vaccinated with 2 doses, and this happened within 9 months. The access, we have to have access for all citizens and residents, and even the illegal residents. It has to be there, accessible for all regions and in all sectors. The operation must be of a high quality and in a pleasant experience. We don't want people to wait for a long time. And we utilized the digital system. It wasn't only as assistant to the operation, it was a core of the operation, and we're counting and recording everything. And everyone remember the vaccination status in Tawakkalna app. If we couldn't capture every vaccination episode, it wouldn't be feasible. So we could vaccine 66 million doses within the kingdom. These doses, out of them, we could give 25 million people 2 doses that represent 82.3% of the population. And we gave 15 million booster doses. And we vaccinated 92% of the senior group with 2 doses. We could achieve a good experience, and the overall experience at the end of the program was 92% satisfaction rate, and this is far higher than any service we are providing in the primary care center or the hospitals. In the waste of the vaccine during the program, we ensure that we don't have much of waste. You know, with the cold chain, there is a chance if you don't prepare the vaccination at the right time, at the right amount, you might lose some vaccination. So we minimize the loss of the wastage doses. The most important thing in a huge project where you work with many stakeholders and you work within different sectors and different regions to have a very clear governance. So there was the program management based in the immunization operations center, and we had verticals, one vertical for the governance, for supply chain, operation, digital, clinical care and education, communication, patient experience, and quality assurance. We had daily huddle to make sure that everything is going smooth and to detect any challenges and to plan everything ahead. This immunization operations center was reporting to a technical committee and then a leadership committee where there is a leadership decision needed to be obtained. And then, as any other vertical of the pandemic, we were reporting to the executive committee led by the vice minister at that time. We were operating inside the vaccination operation center, and when we say operation center, meaning you have visualizing all the data, all the operation, and it's not a matter of visualization, but it's a matter of auditing and to understand the operation, the targets, and any challenges happening in any vertical. The language we use to speak between each other if there is any challenge was the ticketing system. It's going to be really hectic if you use your email or mobile phone and you lose the communication. But in a ticketing system where any issue will be raised and kept and monitored and has to be closed was the way to go further in that program. We're assessing the demand since the beginning, and always we go with simulation, and we know when we are going to achieve our target based on the uptake and based on the other factors. And we put our plan to start with the high-risk group, and the booking system at that time was allowing those of a senior group to take the vaccination first. Supply is very important. You are dealing with a very important cold chain supply process, as well as there is a lot of what we call associated items that has to be in place. So monitoring the supply chain was very important. It was one of the fundamental center or vertical in the immunization operations center. We were monitoring always the supply, and if there is any risk to run out of vaccine was picked early, especially that we are populating appointment and we have commitment to the population to give them the vaccine on the scheduled appointment. That's why we always keep observing the availability of the supply chain. It was end-to-end digital journey, and that helped us, starting from booking an appointment, arriving to the vaccination site, and when you get the vaccine, it was registered in the National Vaccination Registry. It will be automatically reflected on Sihhati and Tawakkalna app to reflect your vaccination status. As well, we used other systems like Tayaqquz to record any adverse reactions. We used end-of-day system to assess the site readiness and the availability of items and to record any events. So investing much in the digital platform was the key and the secret of being on top of everything in that project. We were taking those vaccination sites. We reached to 557 sites, providing the vaccine with a capacity of more than 500,000 a day to vaccine the population. Through a certain step where we onboard and train the staff, we issue the digital users and we install it in the place, and we make sure that we are monitoring and auditing the process and providing the supply. As we mentioned, we had different sites, but the remarkable ones were the major, or the let's say the mega sites, and we had to deal with the mass and the flow. One of these sites had a capacity of 33,000 persons can come in one day. The other one was 25,000. So it was very important to manage the crowd and to get out with acceptable experience and with minimum issues and to ensure quality. A lot of events happening at that time. We encouraged people, that we need to reach to the target, so we encouraged different age group, and we had a lot of activities and monitoring the coverage in every region in order to reach to the immunity of the community. We're monitoring the availability of the appointment on regional level, on site level, and we make sure that everyone has easy access to get the vaccine. We're monitoring the uptake and the trends and how we are doing in terms of the numbers that we vaccine every day, and we pick up any decline or any increase, and we react according to that. We try to engage the population through activities within the sites and through the social media, and we were as well using a unique branding and seasonal branding, encouraging different age group like back to school, Eid, and other occasions. As well, we were sending messages, encouraging people to come and get the vaccine. And sometimes we send automated appointments to some people at a certain risk group, and they come to get the vaccine to make it easy for them. We had detailed documents and manuals to ensure quality. There was auditing and clinical auditing and clinical guidelines. There is a mandatory accessible training for anyone participating in the vaccination program. So they should get a license or certificate before they start giving the vaccine or using the system. As I mentioned, we kept monitoring the operation in the immunization operation center. It's not only monitoring, we audit the data that we receive, and according to the data and the understanding we get, we do the reinforcement needed to ensure the program is going smooth, and we keep and maintain all required functions. We used different systems, as I mentioned, the end-of-day reporting, inventory management of the sites, making sure the sites are ready always, and we kept auditing. We audit the experience, we audit the availability of appointment, the incident report. All of these were kept in well-organized manner, and we kept always ourselves ready to any challenge and how to deal with it in a well-structured way. This is the end, and thank you so much.
Thank you, Dr. Khalid, for this beautiful and informative presentation.
Yes, thank you very much, Dr. Khalid. Now we're moving to our next speaker, Dr. Salim Parker. Dr. Salim, you may take the floor. Dr. Parker is a travel medicine and GP. He's the past president and current executive member of the South African Society for Travel Medicine. He serves as a liaison committee in the liaison committee of the International Society of the Travel Medicine. He collaborates with the Global Center for Mass Gathering here in Saudi Arabia, and he co-authored the Hajj travel chapter in 2018, 2020, and the upcoming edition next year. He's a CDC Yellow Book. He also edited and contributed to the CDC Yellow Book on traveler's health. He's an honorary research associate in the Division of IED and HIV medicine at the University of Cape Town in South Africa. Dr. Parker, you may take the floor, and we're looking forward to hear your presentation.
Shukran for that introduction, and assalamu alaikum wa rahmatullahi wa barakatuh. I want to extend my heartfelt gratitude to the organizers for inviting us to this superb conference. So I've been asked to talk about vaccination for travel and mass gatherings. And normally when we speak about travel medicine, we talk of a traveler and we talk about risk management. And it always is taught that it is this person undertaking this trip during this time to this particular destination. But if we talk about mass gatherings, I want to extend that definition still in the context of risk management, but to include the following phrase, that it's this person undertaking this trip during this time to this destination in the context of public and global health and global security. And I'll expand on that as we go along. Now, if we look at a couple of the major sporting events over the last few decades, for example, the FIFA World Cup, we'll see that there was no major public health issues from 2000 onwards. Yes, there might have been more casual sex during the 2014 Brazil FIFA World Cup. We had to talk about that earlier. And there was concerns about Zika during the Rio 2016 Olympics. But other than that, one or two of them might have had slightly more infectious diseases noted. But other than that, there weren't really major infectious disease problems during these large sporting events. But let's take a step back and look at what can happen when a traveler goes to a particular destination. We know that there's a possibility of transporting a pathogen from the origin to the destination. The traveler can then either give it to someone in the local community or pass it on to fellow travelers. Also, a traveler can pick up a pathogen in the local community at the destination, go back home, and then obviously spread it to those people at his origin and cause an outbreak there. And history is replete with examples like that. For example, cholera, there was about 200 years ago in 1817 during the Kumbh Mela, which we know is a large mass gathering in India annually. Returning pilgrims spread it throughout Asia. And 3 years later, in 1821, during the Hajj, about 20,000 pilgrims passed away due to cholera, showing how travelers can actually spread pathogens. Now, currently, we don't really have major issues as far as cholera is concerned during the Hajj, because there's good sanitation at the Hajj and the Kumbh Mela, but the risk will always persist. And this was again brought to the forefront in 2017, when we know there was an outbreak of cholera in Yemen. And it is well known that 20,000 Yemenis undertake Hajj every year. So the potential existed that infected Yemeni pilgrims who were asymptomatic, and 80% of cholera patients tend to be asymptomatic. They could potentially have brought it into Saudi Arabia during the Hajj and disseminate it from here. So obviously the role of a vaccine was then considered, but because there is firstly an issue with supplies, and secondly with the price of it, it's not always easy to decide which vaccine should be prescribed for a particular mass gathering. Now, let's look in the context of pathogen spread. We know pathogens don't fly. We know, for example, influenza has a vast avian reservoir and that migratory bird spreads it. And of course, we as human beings, we give pathogens wings. Everyone is aware of the 2009 H1N1 swine flu pandemic. Started off, everyone expected it to start off in Asia because that is where most people live, where most of the land mass is, but it started off in Mexico. And one of the mass gatherings there took place over the Easter weekend where about 2 million people attended. And this mass gathering there was thought to have been partially responsible for initiating the spread of H1N1 worldwide. And if we look as to how H1N1 spread from Mexico, it directly followed the route of aircraft travel. So we'll see that it started off in Mexico. The first few cases were then reported in North America, and gradually it spread to North America, following the lines of aircraft travels, to Asia, South America. Australians love going to Mexico, so you'll see they also had quite a number of cases there. And then finally, within a few months, it spread worldwide. Now, it's often been asked, if we had to impose restrictions for travel out of Mexico, what would have happened? Now, mathematical modelings have shown that if 40% of travelers if we had to decrease traveling from Mexico by 40%, the rate of spread of H1N1 would have only been slowed by 2 days. If we had to be more austere about it and decrease travel by 90% out of Mexico, the rate of spread of H1N1 would have only been slowed by 2 weeks, showing the effect of travel on the spread of disease. But we shouldn't only look at large mass gatherings. Let's go to Zimbabwe last year in 2022. There was vaccine hesitancy. There was also measles, for example, was in scarce supply during that time. And 704 children died due to a vaccine-preventable disease such as measles by September 2022, simply because of gathering in specific places. But it's not only third world countries that have this type of effect. There were 44 cases, for example, at a dog show in Slovenia in 2014, over 50 cases in England and Wales at festivals, and even Disneyland in the United States at the theme parks had the spread of measles because it needs over 90% coverage for it to induce herd immunity. And of course, then COVID came along. And just to show the effect of the pathogen on the number of airborne travelers, 2019, about 4.5 million people, a billion people took to the skies. By 2020, this decreased by 60% to only 1.8 billion. It's slowly getting back to those values now. But let's see what the effect of how it was spread easily throughout the world. The European football tournament of 2020 took place in June and July of 2021, and Scotland had its third wave in May 2021. And during that time, just one soccer tournament, which took place in England, in London, to which quite a number of Scottish fans went to, led to the spread of the COVID epidemic in Scotland. 4% of the total number of cases during that time could directly be attributed to people attending the match in London as spectators. And just to show you on this graph here, that is the day of the match. 3 days later, nearly 50% of the cases in Scotland was either due to people who were at the match, that's in the lighter color, or those who were in direct contact with him, showing the effect of traveling amongst these participants. And this has been shown in other parts of the world as well. 31% of cases in Spain were directly related to football matches, basketball matches, or Women's Day marches. And of course, in India, we know that it's considered to have been the largest super spreading event, the Kumbh Mela, which took place in 2021. And that coincided with the time that people were returning from the Kumbh Mela, and at the time when up to 400,000 daily cases were recorded in India as far as COVID-19 was concerned. So let's take a step back and look at what vaccines can do in these cases. Now, we all know about the mandatory vaccines. International Health Certificate of Vaccination demands yellow fever. Hajj, we all know about meningitis and polio. Then there are vocational ones, for example, COVID, if you want to work in certain countries. If students want to go to the United States, they need to show proof of measles and so forth. Then there's recommended vaccines, like, which are destination-specific, like Japanese encephalitis in the Far East. And then, of course, the routine ones, which all of us are familiar with, the booster ones, hepatitis A and B, and so forth. Now, we've all had lots of talks on the IHR, but I just want to point to the second point there, which is that it is concerned about the spread of disease and not primarily with the protection of travelers. And as with any vaccine, we look at what are the indications and contraindications. So we first look at where the disease is endemic. Let's use yellow fever as an example. It's predominantly sub-Saharan Africa, and then, of course, South America. And then we look at the indications and contraindications for each and every travel vaccine. But we have to nuance it to what we do know. As an example, if you look at precautions against yellow fever vaccine, we know it's a live vaccine. And age over 60 is a relative contraindication. But if a healthy 70-year-old is going to an area of outbreak, he should be offered the vaccine. She should be offered the vaccine. So let's look at what are the vaccine-preventable diseases in travel. And you'll clearly see there that influenza is probably the most vaccine-preventable one. And then there's a whole list going down to rabies, rare but inevitably fatal if not treated. And if you look at the number for meningococcal disease, which we all are aware of, it's 1 per 10 million travelers over a 2-week period to a lower income area. But we can't just look at incidence. We have to look at the impact of the disease as well. So even though the incidence of meningococcal disease in travelers is quite low, the impact is high. If someone in a remote area picks up meningococcal disease and doesn't get medical treatment within, for example, 24 hours, the chance of permanent sequelae or even death is over 10%. And why I'm mentioning that is that it's a constantly changing target as far as virtually all the pathogens and vaccine-preventable diseases are concerned. And I want to use the example of the Splendor in the Grass Music Festival, which took place in Australia last year, which attracted 40,000 attendees, but there were 4 cases of meningococcal B meningitis detected there. And even though it is commonly held that the children under the age of 5 and young adults are most at risk, the one death that was recorded there was in the gentleman who was 40 years old. And again here, the vaccine is not universally available. And why I'm mentioning this example is that there's always been the fear of serogroup B, meningococcal meningitis, spreading amongst a mass gathering such as the Hajj. And this has been brought out in the literature on quite a few occasions already. So, in summary, mass gatherings have the potential to seed epidemics and pandemics. Infectious diseases are not very common at mass gatherings, but if they occur, they may have potentially disastrous effects, such as COVID-19 has proven to us. Vaccines have proven public health benefits, and vaccines should be used as a tool, as a public health tool at mass gatherings. And we do have rules and legal frameworks, such as international health regulations, to actually use those ones. And each mass gathering should be considered as this event, at this time, at this destination, attracting these particular attendees. And vaccines should be, for mass gatherings, should be appropriate for the gathering itself. And if we look at, for example, nowadays we know that the vector for dengue is present in Saudi Arabia. So there's always a chance of dengue fever being introduced, and perhaps in 10 years' time, dengue vaccination might be a requirement here. And maybe, as a conclusion and a final remark, maybe one of the legacies of this particular conference should be the establishment of a think tank that would look at what appropriate vaccines should be used for which particular mass gathering. And with that, I want to thank you for your attention. Shukran. Assalamu alaikum wa rahmatullahi wa barakatuh.
Thank you very much, Dr. Parker. Let's now move to the next speaker, my dear colleague and friend, Professor Anwar Hashim. Dr. Anwar is a professor of microbiology and immunology at the Department of Clinical Microbiology and Immunology at the College of Medicine in King Abdulaziz University. He is also the Vice Dean of the Faculty of Medicine in Rabigh Branch, King Abdulaziz University. He is the Director of King Fahd Medical Research Center in the same university. He has academic research as well as industry, biotechnology industry career with more than 20 years experience in Saudi Arabia, United States, and Canada. His focus is mainly vaccine development, immunotherapeutics, and virotherapy development. He's also heading the vaccine and immunotherapy research unit in King Abdulaziz University with more than 150 peer-review publication book chapters. Welcome, Dr. Hashim. The floor is yours.
Thank you, Naif, for this long introduction. And I would like to thank the organizing committee and the WHO Collaborating Center for Mass Gathering Medicine, and Dr. Anas in particular, for this privilege and invitation to be part of this amazing conference. I think we've been talking during these past 2 days and today on travel medicine and mass gathering and the importance of countermeasures and pandemic preparedness. And I think the logical next step is to be able to control pandemics, outbreaks, and to be able to respond in a better way to such threats. I think everybody knows the importance of vaccines. Many diseases almost disappeared in many countries, especially in high-income countries and developed countries. Vaccines are actually considered by many as the second most important invention after clean water. It saved more than 3 billion disease cases, prevented more than 0.5 billion deaths so far. And we heard on the first day that diphtheria, which is almost disappeared from many countries, are coming back because of low vaccine rate, or potentially because of COVID and disruption of the vaccination in some countries. Discovery of vaccines over the time since variolation and sniffing back 3,000 years BC and until Edward Jenner developed the first smallpox vaccine, took longer time to be developed from identification to vaccine development. And these vaccines actually developed with technology. So the more we develop in technology, the more vaccine we discover and develop, the faster, as we see. Even sometimes difficult vaccines or pathogens that we can tackle today, we can develop vaccine for. However, if we look at the different pathogens across viruses, bacteria, or parasites, out of almost 14 to 1,500 pathogens that are of medical importance, we only have around 35, 34 vaccines against these pathogens, which clearly highlights the importance of more research and development and discovery in vaccines. Even if we minimize that number to most important and high priority pathogens, according to WHO or CEPI, we were only able to develop 2 vaccines so far for SARS-CoV, as we all experienced, and Ebola recently in Africa for endemic use. We don't know what's coming. We know disease X, which could be very highly pathogenic and more contagious, maybe, we don't know, is coming. It's just when, we don't know. Other pathogens, other threats still existing or being becoming more problematic, HIV, AMR, zoonotic infections, transboundary infections. It takes a long time to develop a vaccine since discovery. I think the fastest so far is COVID. Took a year or a year and a half, depending on the platform. Yet, it takes even longer sometimes to even reach 80, 70% vaccination rate among populations. Several vaccines are not, we don't have several pathogens that are still a threat that we don't have vaccines for. HIV, Zika, for example. As a vaccinologist, I think development of vaccines is a very complex, complicated, difficult endeavor. It's very expensive. It's very long, usually. The chances of success is very low. 40% of vaccines, they can move from discovery to phase 3 clinical trials, and only around 10% can actually get approvals. Also, there is a huge risk of a change in demand or after development. Examples, HIV and HCV, for example. Even now, if a vaccine is developed for HIV or HCV, would it be as needed as before, especially with the very successful treatment options available and life-saving treatments? So we clearly need novel platforms and development manufacturing platforms that can be quickly adopted to new pathogens. Our experience so far, for example, if we look back at 2009 with H1N1 pandemic, 2015 with Zika, 2014 with Ebola, SARS-1, always there was a delay. Unfortunately, money and industry, biotech, and academia always got engaged late after the peak of the pandemic or the outbreak, and it's always has less impact. So we need coordinated effort and response plans in place for better preparedness. Traditional technologies existing currently cannot prepare us for existing challenges, including emerging pathogens, improvement of licensed current vaccines, or even One Health issue. So we need new technologies, and thankfully we have a lot of new technologies that could prepare us to use or develop new and novel approaches to combat these challenges. They provide new options for pandemic preparedness and response, and they transforming vaccinology with precision and speed. And that was clear with COVID. COVID, although it was based on multiple years, 15 to 20 years of experience, R&D, on viruses, on type 1, what we call type 1 transmembrane proteins of HIV, RSV, flu, coronaviruses, and mRNA that helped to reduce the time from 15 and more, almost by 1 log to 1.5 years. However, is this the right response? It took a year. We experienced more than 7 million deaths that are actually confirmed only cases, more than 7 million deaths and more than 800 million cases because of this gap. So the best scenario would be to develop a vaccine in less than 100 years to be released and used after a pandemic. And that would, one of the proposals is to develop, let's say, 50 to 100 vaccine candidates, and based on surveillance and need, and develop GMP material for these vaccines, conduct phase 1 and 2 trials, stockpile them, and when a pandemic or an outbreak hits, select the most related vaccine and use it in phase 3 and then get approval within 3 months. The current situation, that apart from pandemics or outbreaks, is actually saying that there is a huge gap in vaccine usage or need, especially in low LMICs compared to high-income countries where they actually represent very high value market share compared to almost saturated demand supplied with vaccines compared to low-income or medium-income countries. A huge demand is needed, not enough supply, and part of that is some of the trends that we observed, for example, outsourcing or localization in some countries where actually it doesn't mean localization, it doesn't mean access, it doesn't mean equity to vaccines. For example, conducting clinical trials or even manufacturing vaccines, such as what happened during COVID in Brazil, phase 3 clinical trials didn't guarantee access. Manufacturing of vaccines in India didn't guarantee access. So COVID exposed the importance of localization or regionalization of manufacturing, and several countries already taken measures. There is a clear gap in OIC, LMICs, Africa, in manufacturing. Many countries remain underserved, and government funding and advanced purchasing procurement help developing vaccines. All these trends clearly highlight the importance of vaccine localization and regionalization, including economic, healthcare, and strategic benefits. Most importantly, a return of investment in immunization, for example, against 10 selected pathogens shows that ROI is around 19 to 26 US dollars based on cost of illness approach, and actually goes up to 50 to $52 based on value of statistical life approach. So the importance of localization is clearly important. Market is huge, is expected to even grow larger in the next 5 years to $80 billion. That without accounting for COVID. Hajj and Umrah, other mass gathering events are also a need for, there is a huge need for vaccines and vaccine localization, sometimes for viruses or pathogens that are not of great importance to the rest of the world, only with regional and local needs. Hajj and Umrah is expected to go up to 30 million pilgrimage by 2030. So what are the challenges? There are actually many. I tried to list some of them. Investment. Always there is a huge capital investment required. There is ongoing fixed and ongoing operating cost. It's estimated to be $50 million per antigen sometimes, depending on the platform and the technology. There is always a limited partnership due to reluctancy in investment in tech transfer between MNCs, multinational companies with unproven companies who could grow and become a competitor in the future. There is always a need for specialized equipment, personnel, sometimes inadequate regulatory capacities, and inadequate R&D, lack of clinical trial expertise. Pricing and competition is also another obstacle and challenge. Larger firms and MNCs already paid off most of their capital and their costs, so they can sell at cost. Complicated pricing strategy and process currently existing. Most vaccines by large companies are based on dual markets, where they actually sell for very high prices in high-income countries and for very cheap prices in other countries, so they make up for the cost. The problem is with peculiar pathogens or infections, where actually the demand is only limited to low-income countries. Time, it takes years. So investors require quick return of investment. Such an endeavor is a very long journey. Expertise and resources. There is a special training and skills that are required for manufacturing, localization, tech transfer, platform technologies, capacities, all of that. Several countries already established similar training programs. We here in Saudi, in King Abdulaziz University, established a biomanufacturing training program for 2 months as a starting point in collaboration with the local and international private sector. Change in landscape, as I mentioned before, it could happen due to, for example, novel therapeutics that could limit the need for vaccine. Regulatory standards also is a limitation. So how do we...
Dr. Hashim, the time is nearly up, so if you
Okay,
could
last
wrap
slide.
up. Sorry.
So the mechanism of localization is to address all these challenges by determine the need, conduct needs an assessment, improve the capacity, prepare for pandemic, and get unlimited government support and incentives. Thank you very much.
Thank you, Dr. Anwar, for this comprehensive presentation regarding vaccines and how COVID factored in its industry. It's my great pleasure to present to you our next presenter. He has a really close connection to me. I would like to present to you my supervisor for my PhD. He is an academic. If he could go to the podium, Dr. Haroon al-Rashid. He is an academic academic travel physician. He's currently working as a clinical associate professor at the Faculty of Medicine and Health in the University of Sydney, Australia. He undertook pediatric and tropical medicine training in Bangladesh, Turkey, Saudi Arabia, and the United Kingdom, ultimately receiving in 2009 Doctor of Medicine degree from the University of London. He is also a fellow of the Faculty of Travel Medicine, Royal College Physicians and Surgeons in Glasgow, United Kingdom. Also, he serves as the regional member of its executive board. He is also a fellow of the Royal College of Physicians, London, UK. He is also an active member in the International Society of Travel Medicine, and he serves on its Research and Awards Committee. He is currently serving as the Honorary Secretary of the Australasian College of Tropical Medicine. He also co-leads the Mass Gathering Medicine Node in Sydney Infectious Disease Institute, also previously known as the Mary Bashir Institute. So please welcome Dr. Haroon al-Rashid to the podium, and he may start his presentation.
Thank you. Assalamu alaikum wa rahmatullah. I would request the timekeeper or moderator to remind me, because I think I have got many more slides than I can afford in the next 15 minutes, inshallah. So I would like to, I can't afford to start my speech without acknowledging those from whom I have learned. So the main two things we have done over the last few years is conducting our cities with the help of wonderful PhDs, including, as you can see, Sheikh Dr. Bukhari, and many are here, Muhammad Al-Falali, Dr. Mamoon, and many more. And one very important thing I would like to tell today, alhamdulillah, I'm very proud that all of these students not just finished PhD and brought along important skills, they brought prizes and awards from Australia and maybe internationally. So there are cities that we do generally. If have got just to share in few seconds, slides, the points that we start. First of all, announcing it in a letter, for example, in Lancet or CID. Then we do a systematic review. Then we do a survey to understand the field, people's understanding and practice. And then we do a pilot. And then we do the final RCT. What I mean is that to conduct an RCT, essentially we spend nearly 4, 5, 6 years. So you've got a son or daughter starting in medicine first year, will finish by the time you finish your RCT, inshallah. So my talk is today epidemiology, as you know, epidemiological triad, host, agent, and environment. So I'm going to first of all talk about the host. Host means the participants who take part in a mass gathering. The important message here is that they are all adults. In religious mass gatherings, slightly older, middle-aged people. And in sports mass gathering, a bit younger, as you can see, 25 to 35. And in religious mass gatherings, mostly male to female ratio is pretty similar. To be precise, 53:47. And in the last year's Qatar FIFA 2022, majority are males, 63%. I think my colleagues are here from Qatar, inshallah, they can confirm. And also they often have various pre-existing medical conditions, roughly about, say, to summarize this slide, about 1/3 of them may have some pre-existing medical conditions, and they're all adults. So I said that these are all adults. Children generally don't attend mass gatherings. However, at times they can be the main sufferers of infectious disease. So in this slide, as you can see, I showed a map of Europe. This outbreak happened meningococcal W135, and then we used to call, which we currently call meningococcal MenW simply. 90 cases of these 90, only 12 were Hajj pilgrims, as you can see, and the rest 72 were contacts, and majority of these contacts were actually children. They did not go to Hajj, but they had the disease. So the message here is that although children don't attend, children that can suffer from infectious disease that can spread from mass gathering. Now environment is all the slides, as you can see, very crowded environment in all mass gatherings. Here I have got shown pictures from Kumbh Mela, Hajj, and World Youth Day, and often participants are exposed to smoke, dust, pollutants. Contact with animals may happen, although it's not very regular, but it may happen. Environment, and this is this slide. This slide is about the climate of Mecca, as you can see, pretty much dry. So regarding the agents, we have got a publication just a few years before COVID. This map summarizes actually what different organisms cause outbreaks in mass gatherings. On the right side, I have summarized, as you can see, meningococcal, influenza A, B, measles, mumps, and I have added pneumococcal and COVID, because COVID is now an important issue, cholera and hepatitis. To summarize, actually, the organisms that can readily transmit, for example, influenza, meninge, are important here. The organisms that need a vector or need a parenteral administration are not so important for mass gathering. I mean, this may happen, you may find a few cases, but won't cause outbreaks, likely, unlikely. So historically, we get some historical descriptions from the explorers, someone like, for example, Ibn Battuta. As you can see in the map, he was born in somewhere here in Tangier, and then came on Hajj, and then made a journey. Almost, half of the world he visited, Asia, China, including China, I mean, and East Europe and Africa. So he mentioned about protracted diarrheal illnesses he had when on his journey to Hajj. He did not mention about plague, but he said that he encountered Black Death of Europe. But the other historians say that at that time plague was there in Hejaz. Now another historian again, he's from Europe. Louis Burkhardt also mentions about malaria, typhus, diphtheria, plague. He actually adopted a Muslim name, mashallah, Sheikh Ibrahim bin Abdullah. Anyway, smallpox vaccine is the first vaccine to be discovered and used for a human being, and the first vaccine to be used for Hajj pilgrims. It was used in early 20th century, but we don't know when smallpox outbreaks started in Hajj, but we do know that in 1949, there were about 500 cases, 1/3 of whom died. The most important, possibly, if I may, is the cholera outbreaks that repeatedly happened between 1831 and 1918. So cholera outbreaks, when happened, Arabian government at that time set up 5 quarantine stations, including one at El Tor. I mean, I think the Arabic way is calling Al Tur, Tur Sinin, and in that, in this picture, I'm showing the red arrow here, is Robert Koch. These Koch's postulates, you might be knowing, who won Nobel Prize in 1905, I guess. He was sent from Germany, and one of his team members, Felix Goslik, discovered El Tor, Vibrio El Tor. So El Tor is very much linked to Arabian history, our Hajj. And cholera was not just in, I think Dr. Salim Parker also mentioned that cholera outbreaks, repeated outbreaks happened in Kumbh Mela. In Hajj, this is 1986 is a very important milestone here, when the last as you can see, I have highlighted. Few cases of cholera was still reported mostly among non-Saudi pilgrims. But during that year, most importantly, if you look at the gastroenteritis was the commonest infection in 1986. Now, if you go to 1987, the first big outbreak of meningococcal A outbreak happened, affecting pilgrims coming from Asia, as you can see, 2 countries in Europe, UK and France, and some people from Africa. But then we got the next outbreak in 2000 affecting many other countries, including North America and Far East. Meningococcal outbreaks, people often ask us, does it happen in non-Hajj mass gatherings? Simple short answer is yes, it may happen, but generally outbreaks are smaller. You can see even MenB is also listed, but just one case. So anything can happen. Meningococcal vaccination is mandatory, but often uptake among, I have, summarized 3 groups here, some domestic pilgrims, some healthcare workers who work at Hajj, and a minority of overseas pilgrims miss it out. Overseas pilgrims often have a record of vaccination, but they are not properly vaccinated. Now, currently, the respiratory infections, I will skip this slide, it's very important, and mashallah, this is a very beautiful study conducted by my colleague Philippe Gautret from France. He's showing before the top panel is before, the middle panel is during and after Hajj, and all red marks showing some viral pathogens detected. And if you can see, 4.8% I've highlighted here in red before compared to 38.6 during and 11% after Hajj have respiratory infection. So it multiplied many times actually, the attendance. So influenza has been reported in other mass gatherings, including World Youth Day in Sydney. And we have explored the effect of vaccination and found that vaccine is effective. Often vaccine mismatch happen. And mashallah, Muhammad Al-Falali here, he has published a very beautiful report. As you can see, all red means mismatching, green means matching. Often in different years, mismatch happen. And we did some in collaboration with smart people like Eddie Holmes, you might be knowing. He's the very renowned person who worked a lot on SARS-CoV-2. We found that we explored the genetic distance between circulating and vaccine strain, and that we found that often mismatch happen at a very molecular level. And this is about I'll mix this. We did a big face mask trial. I'm not going to really detail. So pneumococcal disease is also very important. I mean, pneumonia was before 1986, incidence was 4.8, roughly 5%. But later on in 2005, a study among Iranian, very big study, showed that the incidence could be as high as 340 per 100,000. So causative agents often, pneumococcal streptopneumonia often isolated, but not always very high. It may range from 1 to 54%. So finally, you have done, mashallah, very beautiful study on COVID in the last Hajj. So, and you found that the COVID actually, you managed it very well, mashallah, congratulations to you. It was actually even lower than the national average. So other VPDs to mention, just name measles, mumps, rubella, hepatitis A. Tuberculosis has been documented, but in particularly certain populations like those who have underlying conditions, and often high incidence of pertussis have been reported even at Hajj. So antimicrobial resistance is a very important topic. I think it's been discussed, and vaccination programs for antimicrobial resistance, I think, should be thought of. I don't say that there is another vaccine for resistance, but what I would like to say is that if we maximize the use of vaccination, we would be able to minimize use of antimicrobial agents. And mashallah, Hamid Al-Bukhari has done a beautiful study in 2018, recruiting 163 pilgrims with URTI, found that essentially majority, 91% had no bacterial infection, but yet received antimicrobial drugs like amoxicillin and azithromycin. So you have to think how we can minimize those. The way forward is, the first important topic I think should be is that climate change is happening and epidemiology changes with the climate and weather. And hot weather also affects the logistics, like for example, vaccines that need ultra low temperature in some poor countries, this may affect. And we have to think of some other RCTs. We have started already a pilot study on hand hygiene, actually completed. Now, use of artificial intelligence have been already discussed, but inshallah we are in discussion with a big team in the UK who is willing to use AI in detecting outbreak. Just one slide here. Artificial intelligence has been discussed during surveillance team, but one important point here is that, yes, thank you. AI-enabled drones, I have shown a drone here. AI-enabled drones can be used to broadcast messages, announcements, and alerts. So you can send the drones to alert the people, hey, it's very hot, move away from there. Or there are lots of people with respiratory infections in this area of Mina, please move away. So I think with that, I would like to first thank you very much. I think, yeah, thank you very much, that's all.
All right, thank you very much, Dr. Rashid. So now we move to our last but not least speaker, our colleague, Dr. Halima Serehi. Dr. Halima is an ID consultant and infection control hospital epidemiologist. She's the Director General of the General Directorate of the Communicable Disease at the Ministry of Health since 2021. Before that, she served at Wiqaya Public Health Authority as Executive Director for Surveillance and Response, and then later on as a Global Health Executive Director in Wiqaya. She received her bachelor degree in medicine from King Abdulaziz University, and she obtained the Saudi Board in Internal Medicine, followed by a fellowship in adult ID. Dr. Serehi also completed a postdoctoral fellowship in infection control hospital epidemiology at the University of Maryland in 2017. Welcome, Dr. Serehi, and the floor is yours.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Dr. Naif, for the introductions, and I'm honored to be here today with a distinguished speaker. Today, my presentation is about policy and vaccination recommendation. How can I move it? Okay, thank you. So I think my presentation today is a basic for all presentations that already been presented by our distinguished speaker. So as mentioned by previous speaker, that vaccine is one of the most successful public health intervention of all time. Millions of lives have been saved since the introduction of the vaccinations, and much work have been devoted to the development and testing of the vaccination and leading ultimately to their use in a population. However, availability of any product does not ensure their appropriate use. That's why many policies have been developed and implemented since vaccination were first made widely available. Vaccination policy vary from country to country. Some countries are mandating them, and some countries are recommending them, and this is based on a local epidemiology and a cultural context of any country. When we're planning any vaccination committee, usually we need a vaccination committee, whether at a global level or at a national level. Globally, there is a SAG on immunization, which is Strategic Advisory Group on Immunization, with a mandate to advise the WHO for vaccine policy development and also for any immunization-related topic. And at the national level, there is a National Immunization Technical Advisory Group, which is a multidisciplinary body of national experts, provide an evidence-based recommendation to policymaker and immunization program manager. And usually they develop the recommendation based on reviewing and evaluating the available evidence and incorporating them into the local epidemiology. Most of the NETAG, they use evidence to recommendation process. This process is a systematic approach that begins with developing country-specific criteria and ends with developing recommendation. So the main 4 steps of the evidence to recommendation process, it's 4 steps. Step 1 is drafting the policy questions, followed by the element need to be considered for this policy question, and then collect the evidence for the policy question, and finally drafting the recommendation, come with the consensus. So when the NETAG use the evidence to recommendation process for the first time, usually they need to have the prerequisite step, which is the generic criteria and evidence to recommendation process framework. And this is a step only done the first time. Once it's established, it needs to be incorporated into the NETAG SOPs and to be used for the following process. Usually this step should be conducted by the whole NETAG member, and the responsibility for the other step of the process is to be determined by the chairman of the NETAG, but usually from step 1 to step 3 is to be conducted by the working group and the secretariat, which is the working group composed of a representative from the NETAG and the relevant expertise from the national level. And then the step 4 usually need to be conducted by the whole NETAG member. When we go deeply for the prerequisite step, which is the main step that the prerequisite step need to be included in any process, which is focused mainly on identifying the generic criteria and factor and element, and come up with the framework that summarize the synthesis of the recommendation and make it easily to be presented for recommendation. So the generic criteria, we have 7 generic criteria. The first one, the criterion is the problem and the benefit and harm of the intervention, value and the preference of the target population, acceptability to the stakeholder, resources use, equity, and feasibility. And for each one of these criterion, there are a list of factors that need to be linked to in order to make sure that all relevant aspects of this criteria have been addressed. And one of two elements also have been added to the factor to make sure that to make sure that the way of collecting the evidence against these factors are systematically well controlled. So we'll go deeply for the criteria. Let's say the criterion one, which is the problem. A couple of factors need to be considered: the burden and epidemiology of the disease, clinical characteristic of the disease, use, and the cost of the healthcare, alternative preventive and control measure, and also regional and international consideration. When we go deeply for the burden and epidemiology of the disease, we have to assess the frequency of the disease, severity, social impact, serogroup and serotype distribution, and also for the clinical characteristics, signs and symptoms, long-term complication, medical management, and also we need to assess the implication of the primary, secondary, and tertiary care that required for the certain disease, also availability of any alternative preventive measure, and their effectiveness, cost, and practicality. And also the most important point for the first criterion is to assess the international burden of the disease and assess the disease potential for international spread and causing epidemic and pandemic. For criteria 2 is the benefit and harm of the intervention, which assesses 3 main factors: the efficacy and the effectiveness of the intervention, with the different element behind it, which is the efficacy and effectiveness estimate on the disease itself and on the hospitalization and death, immunogenicity, duration and protection and waning of immunity, and interference with the other vaccine. For the harm factor, we need to assess the type and the frequency of short and long-term adverse effect, risk group affected, as well as the potential safety concern or contact of vaccine recipient. The indirect effect of the intervention, so the herd immunity protection, also the potential impact of some of the strain selection in the intervention and emergence of non-vaccine serotype. For the criteria 3, value and the preference of the target population, we need to take into account the perception of the target population of the intervention and difference by subgroup of the target population, also the demand. And this is here just the elements that need to be considered for each one of these factors. For the criterion 4, acceptability to the stakeholder, 3 main factors need to be considered when we're collecting the evidence: acceptability of the intervention to the stakeholder, and also financial and ethical programmatic consideration that may affect the acceptability of the intervention by the stakeholder. Criteria 5, which is the resources used, we have to assess the resources used and a cost related to the intervention, and given to the detail whether this is the direct cost, the cost of the vaccine, material, vaccination, delivery, and indirect cost, either training of the healthcare worker or supply chain expensive of administering the intervention. Also the social impact and the economic impact of the intervention need to be considered. Criteria 6, which is the equity, and there are 3 main factors need to be considered. The first one is the access to the intervention, universality and accessibility of the intervention, especially to the hard-to-reach population. And we have the ethic and legality of the intervention and the stigma that's around, that may attach to some of the intervention or even to the disease itself. Criterion 7, which is the feasibility, the vaccine characteristic, accessibility, resources, and information management, also availability of any surveillance, whether for the disease surveillance and reliability of even the adverse event surveillance, global and regional and local experience vaccine availability. This is just in detail for the vaccine characteristic. We have to assess and collect information around the vaccine presentation, formulation, dosage, administration schedule, flexibility of the vaccine, cold chain, and logistic requirement. And also, this is the element for the other factor need to be considered for the feasibility. So after all these, this is the only, as I mentioned, this is a prerequisite step, but once it's established, need to be incorporated into the SOP of the NETAG and need to be used for the following process. However, it's up to the NETAG to choose which one of them are applicable to the question under consideration or any immunization-related topic under consideration. Some of the country, they omit some of these factors, and some of them, they change the terminology, and some of them, they lump these factors together. So when it comes to the evidence to recommendation process, the step 1, which is the drafting the policy question, usually drafting the policy questions either raised by the Ministry of Health and addressed to the NETAG or raised by the NETAG itself. Such an example, should vaccine X be introduced in a certain population or in all population, or even just reviewing the schedule of vaccine. And there are 3 aspects need to be considered when we drafting the policy questions. Number 1 is the intervention, the population under consideration, and the goal of the intervention. For step 2 is the element need to be considered. As I mentioned earlier in the prerequisite step, there are a comprehensive element and factor that is already included in the generic criteria. However, we need, in this step, we need to just choose the factor and the elements that are really specific and relevant to the policy questions that under consideration. For step 3, which is the most intensive part of the evidence to recommendation process, it's really need to collect an evidence and the selected factor and element that already have been chosen in the previous step and consider the quality of the evidence on the benefit and harm of the intervention. This need sufficient time and resources. Also, relevant expertise need to be included in this step. The last one is the recommendation. Usually in the final step, they draft the NETAG decision, the NETAG recommendation, and present it to the NETAG committee. And the NETAG, they're going to discuss and vote and come up on the consensus on how we draft the policy and whether this NETAG recommend the intervention or the NETAG recommend the intervention for a specific population, or the NETAG does not recommend the intervention. And finally, come up with the NETAG recommendation policy brief that may be developed to inform the Ministry of Health on the NETAG recommendation and the evidence behind each one of these recommendations. I'm going to conclude my slide with this presentation of the slides. Thank you very much.
Thank you, Dr. Halima, for this beautiful presentation on the backstages and the decisions that are happening just to inform or just to approve a vaccine or implement a vaccination program. Also, I would like to thank all of the presenters for their beautiful presentations and informative speaks today. As we've seen with our esteemed speakers, immunization and vaccine makes use of most of what has been spoken of in this conference in regards to logistics, big data, governance, and such on. Now I would like to start the part where we can ask our esteemed guests any questions. I know me and my colleague, Dr. Naif, have several questions, but we would like to give the chance to the audience to ask if they have anything, just if someone could give them the microphone. Anyone have a question? Here in the front, please.
Assalamu alaikum. So thanks everyone. It was really, I enjoyed the presentation with such expertise. So my question will go in the beginning to Dr. Khalid. And perhaps I still recall his call early in the pandemic about the mass prophylaxis or mass vaccination program and the discussion we have. So my question is, given and reflecting upon this major investment and the experience we have gained from, and with our need in Hajj or in general mass gatherings for vaccination, what are the main aspects you see as we believe we can contribute to the global stage upon sharing our experience for the digital certificates of vaccination, as we're aiming to have it as something that will help us and facilitate the security and safety for events, so we can ask other countries or other organizations also to adopt this and to be part of the system, so we can facilitate it and have this implemented across, to make sure that as much as possible everyone who's attending as safe as possible.
Oh, thank you so much, Dr. Anas. I believe the experience of having the vaccination documented in a way that you can track and trace the immunization, and you can have an assessment of the coverage rate is very important. Now we are in Saudi Arabia moving, and we learned from the experience of COVID-19 that we are registering now even the basic and childhood vaccination, seasonal flu vaccination, all are digitized and reflected on the vaccine and phone app as a digital certificate. I believe we can move forward maybe with WHO to have maybe a unified platform for the WHO maybe that can reflect certain accredited centers of the vaccine, and this will make it much easier. Like for Hajj, when we require certain vaccination before Hajj, so it will be documented and reflected and integrated through that platform. For travel medicine as well, to prevent having some infections, and if there is like a requirement of certain vaccination, it can be documented as well from these dedicated centers. I believe from that experience it's not hard. We can do it, and I believe we can add it to the globe if we suggest so to the WHO. Thank you.
Okay, any other questions? Also in the front.
Once again, thank you so much for very, very informative presentation. I think a lot of work has come out of COVID. It's been a great challenge, and I think globally the challenges, such challenges do give us opportunities, and we have cashed those opportunities. And as one of the speakers said on the first day, it was a gift. Definitely tough gift, but I think some excellent meaningful coming out in form of global health security. So I think talking in particular about vaccine production and all that, I being member of the Gavi board and also the Council of IVI Korea, and having worked with COVAX, what I see, I think regional production has to be enhanced. We did hear about in this session that is really, really encouraging. And as we move on, because I think the biggest game changer during COVID has been the vaccine. So I think the regional production, as Gavi is also laying stress, and it's right now more toward the African side, and we already have a model for messenger RNA technology transfer, whereby Dr. Parker will bear me out. There is a hub and a spoke model. The hub has been established already in South Africa for the messenger RNA, and there is no more requirement of every other country that has been selected for production of COVID. And there are other regional requirements. We have been hearing a lot many vaccines. So I think the time has come where I would request the EMRO region to look into it and how we can boost in our region, inshallah, this thing in the near future. Thank you so much.
Thank you for this comment. Any other questions or comments from the audience?
You can go ahead. There is no question from the audience. I would like to go ahead with a question. So we've seen what happened with the COVID vaccine development. It was compressed, and as Dr. Anwar said, it's like 1.5 years instead of 15 years. And that's, as a scientific community, we know it's nothing left out of the stringence and vigilance and regulatory pathway, just like a matter of everybody coming together to compress the process and to talk to each other, to sometimes stagger the steps for the phase 1 and phase 2 and phase 3 and regulatory approval and so on. But, so the scientific community may be happy with this because they know it's done properly, but the public had the concern of, is this a short time? Is it affecting the outcome of the vaccine? And we know it's not, it's no. But what would support COVID vaccine, even for the future, is the post-market administration, post-market studies and post-administration studies. And Dr. Khalid also mentioned that a huge data has been generated in Saudi Arabia, and I'm sure for other countries as well. So my question, maybe to start with Dr. Khalid and then Dr. Hashim, is What are we doing with this post-marketing studies, post-marketing data, post-implementation, if you like? So we have all of that data. Are we doing anything with it? Is it going to inform our maybe seasonal COVID vaccination for Hajj and for mass gathering if needed? Where are we with that direction, and what's your views on this?
Thank you so much. It's a very important question. I'll take it in two parts. The first part, which is what do we do with the huge data that we got? Actually, we had a chance to get to know the community and the population more through these data. You remember before getting the vaccine, there were a set of questions, the location of the population, and we've been able even to track where was the most or the highest rate of mortality or morbidity at that time. Some researchers, they conducted certain studies based on the information that we have collected. I remember one of the studies, maybe it's not published yet, but they checked about the symptoms. It was not for the vaccine, but it was for the swabs. We were asking about the symptoms, and the most, let's say, sensitive, or let's say the most specific symptom was red eye in COVID infection. Those with the red eye, they have highest probability to get a positive test. As well as from the data that we having right now, we can design the uptake, and we can simulate what is the coverage that we can attain. COVID vaccine now, according to the scientific committee, will be part of the seasonal vaccination. I hope it will be in a format, in an easy way, like the flu vaccine, because it was a horrible operation when you have the cold chain, you have to have the -20 or -80 refrigerator, and you have to prepare it and to give it within time. It wasn't easy at all in an operation point of view.
Thank you very much, Dr. Khalid. Dr. Anwar, maybe you want to elaborate, especially on what's the long-term studies on vaccine effectiveness and immunogenicity?
Yeah. Well, I think I second what Dr. Khalid said, and at the same time, I think we have to be very scientific in our approach. I think mRNA technology is not a legacy technology, so we need, especially with the new vaccines, we need to look and keep monitoring the outcomes, especially with the longevity of immunity and cellular immune response, for example, which has been the main discussion of the effectiveness of mRNA vaccines compared to legacy technologies such as protein or inactivated or viral vectors. Even viral vectors, although I think it could be monitored at the same time. I think what we could do also, which is a point of discussion, is randomization after post-marketing. And we capitalize on the mass vaccination and try to gather as much as data as we can to understand the effectiveness and side effects and other aspects. Also, I think, well, maybe I'll jump to another point, which is more relevant to regionalization of vaccines or manufacturing, rather than what already we covered on post-marketing monitoring. I think that will take a lot of efforts from everybody. I think it's not a single person or a single country or job. I think it requires coordination between many players, not only governments, but also scientists, NGOs, VCs, venture capitalists. Requires streamlined procurement, pooled procurement, pooled streamlined regulatory aspects to ensure usage and equity and accessibility of vaccines. As we saw in Dr. Khalid's presentation, a lot of wastage that could have been used somewhere else, and that because of coordination. I think all these aspects are important to be looked at, planned ahead, and we should learn from all the mistakes and lessons that we experienced through COVID.
Thank you. Back to you.
Thank you. Is there any other questions from the audience? Just check. Yes, we have one in the middle.
Thank you very much for the nice presentation from all of you and the distinguished moderating. And my question is about the vaccine against MERS-CoV. And as we know that there were ongoing efforts to develop vaccine against MERS-CoV. And just want to know how will the development of COVID-19 vaccines will accelerate and help in the process of vaccine development against MERS-CoV. Thank you very much.
I hope so. The issue with such infections or pathogens is the need, limited need, similar to, for example, Ebola. And the market lacks the dual market business model. So MNCs, the big four, for example, or big 10 companies in the field, they need to be convinced to be involved. And usually regions suffering from neglected diseases or endemic diseases such as MERS, they lack the capacity. The best that comes to maybe fill-finish capacities, not development per se from scratch. So I think, again, it requires coordinated efforts. It requires investment from private, from governments. Most importantly, I think, yes, we can learn. We learned a lot from COVID. I think actually COVID vaccine was developed based on previous research, R&D on other viruses, including coronaviruses, SARS-1, including flu, which are similar viruses. So I think we learned a lot of being done to improve the vaccine. I think mRNA technology is very promising to be adopted to, and we are already working on that with for example, Moderna on mRNA vaccine for MERS. Thank you.
Thank you, thank you. I think we're going to have our last question because we need to conclude soon. Is there any questions from the audience? I have a question for Dr. Salima, if you don't mind. Regarding the future of vaccination policy and in regards to Saudi Arabia hosting the Hajj, is there any trajectory for new vaccinations or new implementations of policies upcoming, do you think? Especially with what we've seen in this presentation with the meningococcal B variant also.
Thank you, Dir, for these questions. I think this is really important. Actually, every year for the mass gathering, the vaccination policy have been reviewed for any diseases that is considered as a risk for the mass gathering, whether during Hajj and Umrah, as Umrah is a continuous risk for us. And every time all the risks have been assessed, whether those coming to the Hajj, at least from any of the disease that have a potential risk to Saudi Arabia. Already there is some of the vaccination already have been recommended as a mandating to be given for any person or pilgrims coming to Saudi Arabia. However, some of them are only, we are recommending them. Currently, I think one of on the table, always everyone is asking is, do we need to make Min B to be replaced or to be added to the current quadrivalent vaccine for meningococcal disease? And think this will be to be addressed by the NETAC even this year, whether do we need to add it or not. I think the other vaccine under consideration is whether still do we need to mandate COVID vaccine for everyone coming to Hajj or just make it an optional. So I think with emerging, re-emerging of certain diseases and like an outbreak of certain countries and Ebola and other Nipah virus and everywhere, I think whenever there is an emerging infectious disease, the policy needs to be reviewed every year and just to consider whether to be mandated or just to keep it recommended.
Okay, thank you. Thank you, Dr. Halima. On this, we conclude our session for today. I would like to thank each and every one of you for attending, and I would like to also thank again our esteemed presenters. And alhamdulillah, wa salatu wassalamu ala rasulillah. Thank you.
Thank you, everyone. On behalf of the organizing committee, I would like to extend our appreciation for our valued guest speakers and esteemed moderators for this wonderful session. If you allow us for a picture, please. Ladies and gentlemen, we will do the final conclusion and recommendation within 2 minutes.
Good afternoon, everyone. Our honored participants and distinguished guests, we gather here on the final day at the 5th International Conference for Mass Gatherings Medicine with profound sense of purpose and an unwavering dedication to our shared mission. The wealth of knowledge and expertise that has been shared in the past 3 days has illuminated our path forward. With your collective wisdom and passion, we are shaping the future of mass gatherings medicine and looking toward more secure and healthier mass gatherings worldwide and contribution to the global health security. Now, we are delighted to announce the 5th International Conference for Mass Gatherings Medicine recommendation that have been carefully crafted through the collaborative effort of experts, scholars, professionals in the field. And now I would like to hear to Dr. Hani Jokhdar, Deputy for Public Health. Thank you, everyone.
Distinguished guest, thank you very much for your attendance with us in this very informative, very scientifically driven conference organized by our team in the Ministry of Health and كان برعاية كريمة من خادم الحرمين الشريفين. We are very proud to have this 5th conference. Over the past 10 years, this conference is running every 2 years with no shortfalls. Based on the discussions that we had over the last 3 days with 10 pre and post workshops, more than 2,000 attended and more than 18 scientific sessions presented by more than 120 distinguished speakers from 30 different countries and 23 abstracts from scientific papers from many countries. We are hereby presenting to you the recommendations of this conference. Number one, mass gatherings are vehicle to ignite building capacities and work continuously for institutions to foster a positive, sustainable impact on the health systems. We must design our plans and capabilities for such long-term effects. We advocate for allocating resources and funding to support global health security initiatives within the context of mass gatherings. 2, we need a combined top-down and bottom-up approaches to complement a robust, well-designed framework like the key considerations and evidence for mass gatherings and global health security. We need to formulate comprehensive preparedness and response plans encompassing risk assessment, resource allocations, integrations of emergency medical response, team and coordination mechanism. Number 3, it is crucial to adopt a data-driven decisions model and secure investment in data analytics infrastructures and to optimize governance procedures and planning outcome. Number 4, it has become necessity to form international working groups to develop unified health protocol standards and guidelines for mass gatherings. Number 5, we encourage the development of joint research initiatives, sharing experience, mass gathering medical journal, systematic reviews, and best practices to address knowledge gaps. Number 6, we advocate for multidimensional, multidisciplinary, and multi-sectoral strategy for successful risk communication and community engagement, especially for vulnerable groups and for focusing on behavioral health. Number 7, we need to strengthen laboratory surveillance and comprehensive assessment to identify supply chain bottlenecks and devise strategies to ensure sufficient availability and distribution during mass gatherings. Number 8, we advocate for implementing advanced surveillance systems capable and utilizing digital technology and artificial intelligence initiatives of real-time data collection, monitoring, and analysis to track health indicators during mass gatherings. Finally, we need comprehensive immunization and post-of-entry strategies to prevent and control the spread of infectious diseases. That would include digital certifications as a proof of vaccination, as what we had in COVID. We might get rid of the papers. The Saudi MOH is willing to share its experience with other countries and the organization with the WHO Collaboration Center to design such a valid system, and we are looking forward for that. Thank you very much.
Ladies and gentlemen, after this extensive efforts over the last 3 days and the much hard work that we have done over the last few months to arrange for this conference, we promise you it's not the end of it, it's not the climax. Actually, we're going to continue to build upon these activities, and we're open for collaboration to generate more evidence-based and more publications that will document and develop the field with the different experiences. And by that, we conclude our 5th conference. Thanks, everyone. I would like to thank my team, the Global Center for Mass Gathering Medicine, and I would like them to have a special photo at the end here.